All right, welcome everybody. I'm Steve Posnack, Deputy National Coordinator at the Office of the National Coordinator for Health IT. And thank you for the excuse to dress up today. Apparently I can still tie a double Windsor knot with my eyes closed. But in seriousness, thank you for setting aside a few hours in your day to join us for Accelerating APIs in Healthcare, a year in review and momentum for 2021. At ONC, we have a finely tuned compression algorithm that enables us to fit in 4 hours what seems like 2 days worth of content. So you may literally need to buckle yourselves in today. We are going to move at a very fast pace, a snappy rhythm. For those of you that have attended Blue Button developer conferences in the past, you'll recognize a similar setup. We have very brief demos, spotlight presentations, and we're going to have very to little, no time in between. We have over 40 speakers that are presenting today with about a maximum length of 8 minutes. So it'll be very quick. If you blink your eye, you're going to miss something. Which brings me to the format for today. Today's agenda has 3 main sections. First, we will hear opening remarks from federal leaders who need no introduction. Dr. Rucker, our National Coordinator, Administrator Verma from CMS, Matt Lira from the White House, and a guest star, Amy Gleason, who is the USDS CDC Prime Lead. And if you thought that was a lot of acronyms, our second section today in the API Showcase will have 2 parts. The first part will feature presentations from CMS, FDA, AHRQ, SSA, CDC, VA, and NLM. Just a great collection of our federal partners. And if you're not familiar with one of those acronyms, I'm sure they will spell it out for you when they get their chance to present. The second part will feature a wide array of industry partners. It's just too many to name here. Super exciting. It's just going to be just a fun day of updates and progress and momentum. Our third section is going to take us to a wrap-up and reflections panel, where we have asked the patient advocate to moderate the panel this time around. Esteemed panel, lots of colleagues from across the space, and that's pretty much the half day that we have planned for you. For those of you that are social media savvy, we have 2 hashtags, or hashtag and a Twitter handle, I should say. Hashtag ONC API for the event itself, and certainly you can tag our handle at ONC_HealthIT. I'll be your MC all day long, popping in and out. Obviously, with a virtual experience like this, it's going to take a lot of showtime production. So I will keep things moving as best I can. I want to express my thanks to Stefan Konya for leading our agenda, the build, the behind the scenes. Many of you that have come, that have agreed to speak today had many an email from Stefan. So I want to thank him as well as our colleague Cannon Level for all their help in setting things up today. And with that, I am happy to turn it over to Dr. Rucker, our National Coordinator. Over to you, Don.
Thanks, Steve. Yeah, this is really a wonderful day to sort of reflect on the progress we've made and some of the directions that we can go in the future with APIs, application programming interfaces. I think first of all, we collectively have to pat ourselves on the back. I think we really have, as a collective, put in the Fire API world on the clinical side. This is work that really dates back to early work by Graham Grieve in designing the standard, and the SMART grants with Boston Children's and Ken Mandel, whom you'll hear from, other folks who've worked on that. The rulemaking and the prior legislative technical assistance from Karen DeSalvo and Vendel Washington that got us to the point where we now have an information blocking rule that really finalizes putting data in the agency of the patient. Really a very, very, very powerful thing. As part of this clinical API world, we have the complementary bulk fire rule. And what does bulk fire do? I think for the first time, we've all talked, everybody on this meeting has talked about big data, but we've actually not typically had big data, at least not big data that can cross hospital business boundaries in an aggregated way. With the bulk standards, we were really finally going to have the data substrates we need for a learning healthcare system. Very exciting. I think this is going to put a new flavor on how we assess value in healthcare. We're now going to be able to go with rich data sets rather than, and this is work in progress, rather than the narrowly defined quality measures that have been the best we can do before. I know CMS is already putting some work in place in that. Complementing, that this new way of looking at value, our integrating clinical administrative data task force has done some very solid early work in figuring out how to start merging clinical and financial data in a single stream. Right now, we have clinical APIs, we have the financial, transaction APIs, but they really don't meet. It's pretty hard to have a look yourself in the mirror and say, we're really doing a great job on value and quality for the dollar when the data streams don't even meet. So some great early work there that we're doing. I think as that work progresses, we're going to be able to get rid of, over time, some of the real burdens that have come from the disconnect between patients and the payer-provider payment schemes that we've set up in America over the last 50-odd years. And rather than having extraordinarily cumbersome prior auth that just squanders provider resources, irritates patients to no end, we're going to be able to have a lot of these decisions adjudicated real time in a fully computable way. That's early work, but I think it is some of the goal. The Da Vinci Group is working on that. Another related area, early work on read-write APIs as opposed to the read APIs that we've started with in our prior work in our rule. And, as we look at APIs more broadly, the COVID, pandemic, I think highlights another opportunity to start harvesting the value of APIs, and that's in public health. Historically, when you look at public health, going back to literally John Snow and the Broad Street water pump and the discovery of cholera and the mapping of the cholera case reports, the public health apparatus has really had a reporting thing, and often, as we know, mandated reporting. In a world where we've invested in EHRs, where we have broadband most everywhere, and where we now, in most parts of the country, have remarkably robust health information exchanges, we're starting to be in a position to actually move, think about how to move the public health reporting from that one way, not often well curated, mandated type of reporting to where the public health agencies, under their legal authorities, and only to the extent of those authorities, can harvest this richer operational data set that is being collected every day by our state and local health information exchanges from all different types of providers because they actually get out to the last mile. So they see the entire community, they see it in an extraordinarily pro-competitive way. So we're at the brink of harvesting, I think, that great opportunity. Part of that is research that some of the folks here have done on protecting privacy and things like split learning, federated learning that allows harvesting of these data sets, but yet protects the privacy and doesn't actually move the private part of the data. Extraordinary opportunities enabled by modern software and computational approaches. So I think that gives a flavor of things. I would like to turn, first of all, also thank the Office of American Innovation at the White House, Matt Lera, Jared, Chris Liddell, for being absolute stalwarts in getting the API rulemaking and putting that so the American public is going to be in charge. Another person who's done amazing work with amazing creativity in getting the American public back in charge is Administrator Seema Verma. Seema, I'd like to turn it over to you. Thank you for your work in making the API world a real world. Thanks. Seema?
Thank you, and thanks for inviting me. Well, let me start by just extending special thanks to Dr. Rucker and to Matt Lira for organizing this event, and the CMS team, Shannon Sarton and Alex Muggy, for their tireless efforts over the past 4 years. Speaking of 4 years, this week marks the anniversary of the date that I accepted President Trump's nomination to become the CMS administrator. And I did so because it was clear to me that this administration wasn't afraid to disrupt the status quo to make lasting, transformative changes on behalf of the American people. Such fundamental structural changes to the healthcare system naturally have not always made us popular with large special interest groups that have made themselves both comfortable and profitable with that status quo. But after 4 years, I am proud that CMS has not backed down from needed changes when the good of the American patient was on the line. And we have advanced a bevy of reforms that promise to usher in a new era in American healthcare, from price transparency to kidney reform to the historic premium price plunges in Medicare Advantage and even the individual market. But I can think of no more consequential change than our work taken on CMS's own initiative without congressional direction, combined with ONC's new rules to promote the seamless and secure flow of health information throughout the healthcare system. Over the years, interoperability has emerged as the great white whale of healthcare policy, a great prize always seemingly just around the corner, but never ultimately realized. After the previous administration made a massive investment of $36 billion to get health records on electronic systems, the future seemed bright. Patients would no longer shoulder the burden of reconstructing from memory a lifetime of medical information in a moment of crisis, when a quick decision might mean the difference between life and death. Providers would spend less time making and transcribing notes after long shifts, and would have complete patient data at their fingertips, allowing them to avoid duplicate tests and unnecessary treatment. And the free flow of information would inaugurate a new era of medical innovation that would transform the face of healthcare. Unfortunately, that future never materialized, and instead we found that paper silos have simply become digital silos, and patient data is held hostage in individual electronic systems. Over time, the situation has calcified into a status quo that is profitable for large record companies, but bad for patients. So when this administration took over, we understood that in a world where we can communicate instantaneously with someone on the other side of the globe, access our bank account from anywhere, that it wasn't acceptable that our health information capabilities remain mired in the Stone Age. In 2020, faxes should not be the primary means of records transfer. And we're used to a digital experience in every other facet of our lives, and it's high time that healthcare caught up. So we announced our plans at the 2018 HIMSS conference, and with the help of ONC's considerable efforts, this administration has delivered. CMS has overhauled the Meaningful Use Program, which is now known as a Promoting Interoperability Program. Hospitals are now penalized and clinicians lose their incentive payments if they don't give patients their health data. And then we got our own house in order. And just going back a step on that effort, we've seen great compliance. We've seen 94% of hospitals complying and over 70% of doctors' offices. But beyond that, we got our own house in order. CMS launched Blue Button 2.0, Medicare's first developer-friendly, FHIR-based API that links Medicare claims data to apps on beneficiary phones or other devices, so they can have it at their fingertips and share it with whoever they choose. With nearly 4,000 developers in the development sandbox and 74 apps now available, Blue Button is giving Medicare beneficiaries secure access to their health claims data with the click of a button. And such vendors and innovators deserve tremendous credit for attempting to deliver simple, innovative solutions to Medicare consumers. And I hope that more of their counterparts will follow their lead. But impactful as Blue Button has proven in its own right, we have always viewed it as a model for the broader healthcare system. The CMS interoperability and patient access final rule, which was finalized earlier this year, requires that all health plans doing business with the federal government deliver something like Blue Button 2.0 to the 85 million patients in CMS regulated health plans. And that includes Medicare Advantage, Medicaid, and CHIP fee-for-service and managed care plans, and all the insurers offering products on the exchange. As a result, our policies now require these payers to step up to the plate and share that wealth of claims data directly with patients through a secure, standards-based API. We hope these insurers making the investment for their public program beneficiaries will also release claims data to all of their beneficiaries. This rule is, without a doubt, our most consequential reform yet, and it will be implemented on January 1st of next year. But the rule goes even further by requiring plans to share patients' health information with other plans at the patient's request. And this will allow people to take their claims data with them when they move from one payer to another and create a cumulative health record as they go. The rule also requires plans to make their provider directly accessible through a provider directory API, and this will allow innovative third parties to design apps that will help patients evaluate plan networks which are right for them and potentially avoid surprise billing by having a clearer picture of which clinicians are in network. And finally, the rule requires hospitals to support care coordination for patients by sending admission, discharge, and transfer notifications to the patient's doctor so that patients receive better and timelier follow-up after they leave the hospital. In sum, the data unleashed through the interoperability and patient access final rule will create transformation and disruption in ways we have yet to contemplate. But in all cases, providers and patients win by having better access to data. And while Blue Button and the rule have focused on beneficiaries, our data at the point of care pilot that we launched last year gives providers direct access to patient data. Over 588 provider organizations are participating in the Data at the Point of Care project, which is an API that provides Medicare claims data directly to providers to promote better patient care. And it's critically important for providers that are engaged in value-based care who can then have their patients' data readily available. And access right in a provider's existing workflow, there's no logging into another application or portal. But the truth is that efforts such as data at the point of care barely scratch the surface of how dramatically we can drive interoperability. I'm very proud of what we've accomplished, but there's more work to be done. To date, our efforts have largely, with some important exceptions, been focused on getting data into the hands of patients. And this is appropriate because data belongs to patients first and foremost. However, we believe the Fire-based APIs that we have used to expand patient access have significant untapped potential to unleash data and get it directly into the hands of all providers. We need to ensure that patient data from other sources gets incorporated into the health records seamlessly so that the data can be utilized. Electronic health records must finally become truly open and gain the ability to both read and write data in service of better care for patients so that providers and payers alike can make use of the data. And whereas our overhaul of meaningful use used penalties and incentives to drive interoperability among providers, the time has come for full-fledged requirements, vigorously enforced, that clinicians provide data in a digital format to patients. Just as we are requiring price transparency of the healthcare system, data transparency should also be required. Look for more on this from CMS in the very near future. Going forward, APIs, fire standards, and interoperability must be more than simply a project of CMS and ONC. It must be a priority across all of HHS, so our entire healthcare system speaks the same language. So consider the possibilities for the healthcare system if medical devices approved by the FDA were required to be interoperable so that data could flow into the EHRs and be captured promptly. Or if CDC reporting systems also used Fire-based standards. The COVID response would have been easier if hospitals could have reported data directly to CDC from their EHRs. And as reporting requirements grow to support disease surveillance, we must leverage FHIR and APIs to make this process easier for providers. And further evolution and adoption of FHIR standards across the agency and across the healthcare system is the way forward. And while there is more work to be done, a full appraisal of CMS and ONC's record on interoperability reveals an unsurpassed record of accomplishment. The free and secure flow of health information that patients and providers are soon to enjoy represents a massive transformation of the healthcare system. I firmly believe the progress that we have made was only possible because we came into office with a vision, one that was supported by the White House Office of Innovation run by Chris Liddell and Jared Kushner. And as we move towards a competitive healthcare system in which market forces are used to lower prices, increase quality, and boost access, we must make sure patients can be empowered consumers shopping for the best value. And that means that patients must have access to price and quality data and have their medical data to take it wherever they seek care. But the impact of interoperability goes beyond the individual. In the era of the COVID pandemic, the need for data to move seamlessly is critical for public health surveillance, both now and in the future. A truly interoperable system will allow us to rapidly detect emerging infectious diseases and make it easier for providers to share public health data. I couldn't be prouder of the work that we've accomplished over the last 4 years on interoperability, and I hope that the healthcare system at large can unite behind these efforts. Going forward, I hope that large players in the healthcare system need not wait for government to tell them what to do. They can simply act proactively and voluntarily in order to promote the common good on behalf of the American patient. This administration's effort on this issue have improved and refined the work of those that came before us. And for the sake of the patients that stand to benefit, whatever comes next should take the same approach and build on the unprecedented progress that we've made to further advance a system to where data flows with the patients at the right time and right place, advancing a new era of efficiency and innovation. Thank you, and thanks to all of you for the work you do day in and day out to advance the vision of interoperability. Thank you very much.
Thank you, Administrator Verma. Thank you, Dr. Rucker. We are going to turn it over to Amy Gleason for a quick update. We lost your video, Amy. I'll put my video on for everybody. All right. While we have our tech team getting Amy back on track here, maybe we'll turn it over to Matt if you want to go, and then we'll end with Amy. Thanks, Matt.
Yeah, sure thing, Steve. And thank you everyone at HHS and ONC for pulling this event together today. I've been looking forward to it. The past few years with the Blue Button Developers Conferences have been a real highlight, I think, for me and hopefully for the broader community. So the virtual equivalent is something I've been looking forward to. I'd like to begin by thanking Dr. Rucker. His steadfast commitment to interoperability, his expertise and leadership has been an absolute bedrock to making this policy progress. I'd like to thank Administrator Seema Verma. She's one of the hardest working public servants I've ever known. She's absolutely fearless in her commitment to doing what's right for patients at all times. The American people have been exceptionally lucky to have her at the helm. And of course, I'd like to thank the team of incredible public servants defined by their dedication and professionalism that work at agencies throughout the government, many of whom you'll hear from later today for their work in this important issue. I'd like to start by taking a moment to reflect on the progress that's been achieved. You know, when new technology meets public policy, breakthrough transformations are possible. And as Administrator Verma indicated, you know, this has been sort of the white whale for the healthcare community for some time. And I think that there have been moments where the technology was right, but the policy wasn't there. And there were moments where the policy was right, but the technology wasn't quite where it needed to be. And in this moment, the incredible work of technologists and policymakers has finally aligned. The next cycle of healthcare innovation has really begun, defined by the emergence of API-enabled app ecosystems that will transform healthcare throughout the country. A world where data, devices, and doctors seamlessly collaborate together to improve patient outcomes in healthcare. Now, in short, is the time to build. The race to launch the next great aha moment app, as I'll call it, is underway. That critical moment when a new technology transitions from a gadget for early adopters into a must-have for all consumers in our economy. You know, we've seen this with computers, and the first time users were able to use word processing, or with smartphones, the first time you opened the turn-by-turn direction app, or it could tell you the song that was playing on the radio. These moments transform technologies into must-haves, and that is the race underway for our interoperable healthcare system. I'm pleased to report, as you will see throughout today's agenda and beyond, that 2021 is truly poised to be a breakthrough year for healthcare innovation. Beyond the technical progress, and there are going to be people with far more expertise than I who will touch on many of the technical points today, I would like to spend a moment reflecting on the how of how we did this moment, how we achieved this progress. In a world too often defined by what divides us, the way in which this progress occurred is perhaps as meaningful as the progress itself. This could have been yet another issue that fractured the healthcare community. Yet, through the good faith efforts that all of us undertook together, this issue, in my view, has largely unified the healthcare community. It has been bipartisan. It has received support from providers, from payers, from patient advocacy groups. It has united big tech with health tech and startups and venture capital. It takes two people to shake hands. At every step of the way, any stakeholder in this process could have withheld their support or acted in bad faith. And yet what we saw throughout this process was that all stakeholders worked together in good faith. The healthcare innovation community made a decision to work together on real, long-lasting change rather than accept a sugar high of short-term victories and short-term symbolism and divisions. Everyone involved, including many of the participants in today's agenda, should take a measure of pride in that reality. As I conclude my remarks, I'd ask your patience as I may indulge a point of personal privilege. Serving in this role for the past 4 years, it has been a tremendous honor to work with all of you on these issues. The healthcare innovation community is a special one, and myself and my team of colleagues and bosses, Jared Kushner, Chris Liddell, and all of the rest of the team here at the White House who have worked on this, have valued and cherished the opportunity to work on this critical issue. Whether it has been those early listening sessions in the Roosevelt Room, or the Blue Button Developers Conferences, or the dawning days of hammering out the details, I am personally grateful to each and every one of you that helped our country achieve this progress together. No doubt, it has been a challenging year for our country and for the healthcare community. Yet, as I look back on the policy progress that we achieved together in interoperability and the manner in which we achieved that progress, I am filled with boundless optimism that we might finally capture that white whale, and the future of healthcare innovation will be a definitive one for patients around the country. Thank you again for participating in today's event, for the work you have done, for the work you will do, and for the future that we can build together in the United States. Thanks again for your time, and I'll hand it back to Steve.
Thanks, Matt. Appreciate your partnership, and we will turn it right over to Amy. Let's keep it to a crisp 5 minutes, which will keep us right on schedule. Thanks very much. Take it away, Amy.
Thank you. Hopefully my Zoom will cooperate better this time. Okay, there we go. Hi, everyone. So I'm Amy Gleason, and today I'm so excited that I get to share with you an exciting collaborative project between the U.S. Digital Service and the CDC. So this project is called the Pandemic Ready Interoperable Modernization Effort, or PRIME, And it all started in May when it was obvious that not only was the federal government struggling to get complete and timely COVID data, but also that the local and state public health departments were overwhelmed and were struggling to get timely, accurate, and complete data sent to them so that they could use it for action. So one of my favorite values of the U.S. Digital Service is go where the work is. And so we did. We went to 6 different states and met with public health departments, hospitals, labs, drive-up testing centers, nursing homes, you name it. And I'm going to show you a few of the things that we saw. So I know many in healthcare won't be too surprised to see this, but we saw way too many manual and paper processes. The person on the left here is spending her entire day faxing these stacks of paper to different jurisdictions so that they can have the information they need. This National Guardsman in the middle is completing this same exact form twice for every single patient so that they can keep one form and send the other with the specimen. And on the right is a box, an example of lab reports that are coming in on paper to the public health department that they have to open, read, and then manually transcribe one by one to get them in the system. And often this reporting is required to multiple different places, such as hospital aggregate reporting or lab results or case reports, and that requires duplicative work. There are also many new entrants that came into the system, and they were very creative at finding workflows to get them to do a lot of tests in a day. So here you see on the left, this is a workflow bench for a drive-up testing center, and the creative solution in the middle where they wrote in English and Spanish on the paddle so they could hold it up at the windows to tell the instructions to the driver. And on the right, you see the line of point of care testing machines that were churning out 15-minute tests in a makeshift trailer. And the problem was they didn't really have any workflow tools that were there out of the box to help them manage their workflows or to report. And many of these labs had never reported to public health before, so they hadn't done HL7 messages, and trying to get that stood up in the middle of the pandemic and trying to figure out how to get people tested is a lot to ask. On the other side, it also put the public health departments in burden because they got these long queues of people wanting to do interfaces that required a lot of work on their side. And lastly, this put a high burden on the data reporters and the public health departments because each of these connections are point-to-point interfaces from every testing facility, or hospital, or clinic to the state and different county jurisdictions. These are expensive for testing facilities that hadn't previously reported to public health, and it also requires these limited IT resources at the public health to validate hundreds of new lab interfaces as they go forward. And so what we found was really heartbreaking as we watched these public health people accomplish amazing feats despite many technology challenges. But we realized that they really just needed a little help with technology. So we were very excited in late August when the CDC decided to fund and closely collaborate with us to help these local and state public health departments have better, faster, more complete and accurate data so they can take timely action and appropriate action. So our work focuses on 2 projects on the sending side to get data automated out of traditional settings like hospitals and labs, and then out of more non-traditional sites where they're doing a lot of point of care testing, and getting that data into a prime data hub that can receive that data in any format and then transform that and route that to the correct jurisdiction in the format that they need it so that it can come to their disease surveillance system for action like case investigation, contact tracing, and other results. So the first project is the data automation project. So traditional healthcare settings like hospitals and labs have existing systems, but they often lack the automation to report that information. So you'll see on the right, this is an example of a CSV file for the hospital aggregate reporting. And so what we've done is we've partnered with EHR and local IT vendors to create solutions that automate this process. So it can take that CSV file directly out of the EMR or the IT vendor and get that into the HHS system for their daily reporting. We're also providing technical assistance to hospitals, labs, and to the public health departments to accelerate those HL7 connections and to get them validated and up and running. And coming soon, we'll also be taking this to clinical data reporting in different formats. And one of those examples you'll see Laura Kahn demonstrate in the next block for the ECR. I'm very, very excited to talk about our Simple Report project and the Prime projects. And this is going live today at our first site in Arizona. So many of these non-traditional settings, such as schools, universities, and employers, are now testing for COVID-19 using rapid tests with no existing systems to store and report their data. So what you can see on the right is a simple user interface that we've created in a Simple Report app, and that replaces their current paper-based and spreadsheet workflows to make recording and reporting these results a single, simple step. And don't miss the demo of this Simple Report shown live by Paula Braun in the next time slot. And lastly, our data hub also is live today. And this is solving the problem where there are many different senders that all have different formats and different abilities. So some can send only in CSV, some have HL7 or Fire. So these different things like the Simple Report app or labs or hospitals can send to that data hub. And then the data hub can then translate that information and get it to all the different places that need it, the county, the state, and the federal government. And so what we've done is we started with the Simple Report app and taking all of the data that meets the HHS guidance for lab reporting, and we're sending that to all of the right jurisdictions in the correct formats. And that would include sending it to the testing facilities, county, the state, and based on the patient's address where it needs to go. And then we're going to continue building that out for other senders and receivers as we go forward. And this is showing you an example of that. So from the Simple Report long-term care facility that we went live with today, this sends it into the data hub. And then at the state level, they might need it by SFTP and HL7 and have specific fields that they want. But at the county level, they're actually wanting it via secure email. And they also have different fields that they can accept and that are required. And so the data hub knows this and takes the same data that gets the right information to the right place so that they can take it right into their surveillance system for action. So we would love to have you participate. We're very excited about how these projects are helping with COVID reporting. Our local jurisdictions have been great, and we're so thankful for all of the CDC collaboration that we've had. And we would love for you to contact us at usds@cdc.gov if you meet any of these criteria. So a state or local public health department that wants to be a pilot partner, we're looking for more pilots. Also people that want to just participate in research design, even if you're not ready to implement solutions. Hospitals that are manually reporting today and would like to automate that daily reporting to HHS. A hospital or lab that's still using paper, fax, or phone to report or can't report at all. And then any testing facility that wants to use Simple Report to record and report these results. And remember that demo later. And I do want to say that these are pilot projects, so we would love to hear your interest, but do please be patient because it will take us a while to expand this program to a national level. We're starting with local pilots and growing this over time. And thank you so much for your time.
All right, thanks, Amy. That concludes our first segment already, if you can believe it. We are going to quickly transition over to my colleagues at CMS for the beginning of API Showcase part number 1. While they're pulling things up, I did want to note for all of our presenters going forward, everyone's familiar with Zoom by now. There's the share button for your screen and your slides right at the bottom center of the screen, camera and mic phone to the left. And when you're done, please hit the stop share button at the top so the next person can take over. So as I mentioned before, we're going to be operating things like a Formula One pit crew. And for all of you that are track and field fans, this is a 40-person relay race, so no baton dropping. And I'm handing the baton over to Alex and Denise, my partners in policy over there at CMS. One of the last things I'll note as a forewarning, since one of my roles at ONC is to look into the future, we do have a break at 2:30. So now is the time to put in your DoorDash or Uber Eats coffee order in order for it to get delivered to you on time. And with that, I will turn it over to Alex and Denise. Thanks very much.
Thanks, Steve, and thanks for everyone for having us here today. Administrator Verma already gave an excellent overview of where we have been and where we need to go in this API and interoperability space. She talked about the importance of APIs and how we are bringing healthcare into the 21st century with data exchange. And as part of our strategy to drive interoperability forward, CMS has created a new Office of Burden Reduction and Health Informatics, or OBR-HI, which includes my group, the Health Informatics and Interoperability Group, or HIE-IG. Denise and I are going to quickly go over a couple of our key focus areas, and Denise is going to focus or is going to present a little more detail on our patient access API in just a moment. So our office is responsible for coordinating the interoperability efforts across CMS and working on an API strategy that aligns our internal operations at CMS with data exchange in industry. True interoperability includes payers, providers, researchers, innovators. It involves everyone in healthcare. And CMS is in a unique position in that we work with and regulate many of these stakeholders. Our group, the HIE group, is strategically placed within CMS to have an enterprise view of the interoperability efforts that are going on throughout our agency. As we help to promote certain key focus areas, I'd like to highlight a couple of those as you see here. So at the top of the screen, you'll see patient access, which is where we have spent a lot of time and focus lately. Through both our policies and our programs, we have highlighted patient access as a critical part of engaging patients in their healthcare and also a stepping stone to interoperability. And Denise is going to talk a little bit more about our patient access API in just a moment. We also have a focus on connecting healthcare through data exchange, which is really where Fire-based APIs have played a significant role in that data exchange and where we put a lot of focus of our policies that have been out and some of the policies that we are hoping to share with you in the future. We also have an enhanced focus on technology and standards. Technology in healthcare is ever evolving, and we must continue to evaluate our approach to ensure that we are keeping pace. So as you can see from the diagram that's on your screen here, interoperability is not an endpoint, but it's a journey, and it's a journey that we are all on together. And this isn't to say that we won't get there. We will eventually get to a point where we are sharing data freely and securely, but our work to maintain that data exchange will never be over. It will never be done. Technology and innovation is part of what makes our healthcare system great, and it's also always changing, and that is why we need to continue to evaluate new technologies, and we will update our policies to keep pace. And speaking of policies, I will turn it to Denise Sinclair, who is going to give an overview of the Patient Access API.
Thank you, Alex, and thanks everyone for joining us today and for ONC for putting on this great event. So as part of the rapid fire opportunity to learn about so much amazing work that's going on, we're going to focus on just one piece of a larger puzzle that you are seeing laid out for you on this slide. So on May 1st, 2020, CMS released the Interoperability and Patient Access Final Rule that Administrator Verma and Alex have mentioned, and Dr. Rucker mentioned that on that same day, the ONC 21st Century Cures Act Final Rule came out. And together, those rules really put a focus on the value of Fire-based APIs. And as a result, one of the policies in this rule that we are very excited about and that we'll focus on today is the Patient Access API. And that falls under that January 1, 2021 piece of this puzzle. First thing I will mention is we have exercised 6 months of enforcement discretion. So we won't be enforcing the Patient Access API until after July 1, 2020 due to the public health emergency. So what is this Patient Access API all about, and why are we so excited about this first step in the journey? We, in this rule for the APIs, are regulating payers, CMS regulated payers. So what this policy does is it requires Medicare Advantage organizations, Medicaid and CHIP fee-for-service programs, Medicaid and CHIP managed care, and qualified health plans on the individual federally facilitated exchanges to implement, maintain, and test a patient access API. What is that? Well, it's a Fire-based API, and of course we're using Fire R4, that's accessible to third-party apps of a patient's choice. So if I'm a patient and I'm with a CMS regulated payer, I can go to the app store of my choice and I'll find an app that is going to say, help me manage my chronic condition, say diabetes. So I find this app and it looks great, and I go through the process of giving that app my information and consenting to have that app access my data from my payer. And so that then initiates a ping. And what this rule is saying is, payers, you need to have certain data available through this API for that app of a patient's choice to be able to access and use in a valuable and usable way. So what kind of data are available through the API? Payers need to make available claims and encounter data, specifically adjudicated claims, and they have to make available a subset of clinical data as defined in the U.S. Core Data for Interoperability, the US CDI, which you all know well, and we'll hear about a lot today, I'm sure. They also have to make available formulary data. Now, for Medicare Advantage plans that have a Part D component, they do also have to make available prescription drug plans or prescription drug claims, as well as formulary and for Medicaid and CHIP covered drug lists. So you've got your claims data, you've got your clinical data, and you've got formulary information that can then be shared with these apps, so that the data that is going to be most useful and most valuable to a patient can be used and presented back to the patient in a way that can help them be engaged in their healthcare, be the center of their healthcare, and ultimately be more informed decision makers. So for instance, if this app is helping me manage my diabetes, there are certain data elements within the US CDI that might be most valuable. So it may help me track my A1C levels and my weight. And these are things that can very specifically be used to help me deal with my situation in the best way possible. And of course, industry is way better positioned to find incredibly innovative and effective ways of giving these data back to patients through third-party apps. So we've already seen the value and the innovation in Blue Button, so we're really excited to see everything that's coming online for the Patient Access API for patients to use. Now, we know you have a ton of questions about the Patient Access API, and we're not going to be able to answer them in the 15 seconds I have left of our time today. So what I can tell you is that next week, Wednesday, the 9th of December, from 1:30 to 3 p.m., we are having a Medicare Learning Network, or MLN, event to answer your many, many questions about the CMS interoperability rule. We've obviously have wonderful stakeholders. We have a lot of information on the next slide. There's a link about the specific implementation guides, the FHIR implementation guides that are available to support implementation of the APIs. And we'll talk more about that detailed implementation, the detailed implementation questions next week. But we're really excited to have the opportunity to show one piece of a larger puzzle of technology helping patients get access to their data and helping us leverage these data and getting them out of the silos. So thank you, everyone.
Awesome. Thank you, Alex and Denise. I'm going to turn it over to our colleague over at FDA, Dr. Abernathy.
Terrific. And Steve, did you want me to share my screen, or do you want me to just go for it?
I think Stefan may be driving for you. So if we're all set there, then you should be good to go.
Good afternoon. I'm Amy Abernathy. I'm Principal Deputy Commissioner and Acting Chief Information Officer at FDA. FDA is a public health agency, and we regulate many of the products with which you're familiar. We make sure that drugs and biologics and medical devices are safe and effective. We help protect the safety and security of your food supply, and we regulate other products like tobacco, cosmetics, and animal and food and drugs. And we have a core focus on making sure that we have data and tech modernization at FDA that are based on use case driven roadmaps. Today, I'm going to review a program of work at FDA focused on modernizing the submission and review of regulatory data. The work that I'm going to show you is an important advance addressing safety within one of the huge industries we regulate, namely the pharmaceutical industry, and therefore this advance is also critical to public health. We're at a midpoint in the work. We have built and are implementing a minimal viable product and an MVP and ensuring that it's functional for industry and for FDA. As we implement this MVP, we will review results and update as needed with plans to upgrade the work to the main API-based approach. So how does this usually work? Drug makers who conduct clinical trials with investigational drugs are required to review all safety information related to their drugs in order to protect patient safety. Imagine a new drug under evaluation in the United States. This is an overview of the safety data submission process. When you look at it in this view, it looks pretty straightforward. Information is gathered at the sites, packaged by the pharmaceutical company, sent to FDA, put in a database, and reviewed. But goodness, our outdated process is slow and cannot leverage any newer analysis tools like data visualization. So we set about modernizing this, first focusing on a specific type of safety report, the safety reports for investigational new drugs, or INDs. Next slide, please. Certain types of serious safety events must be reported by a drug company to the FDA in an IND safety report within 7 or 15 days, depending on the type of event. FDA, if you can believe it, receives between 30 and 50,000 of these reports per year. And in the next couple of slides, I'm going to walk you through what the current process looks like and the benefits of our future process in development. Next slide. In the current process, a drug maker takes structured data from their safety databases, essentially unstructures it to populate a MedWatch form, and submits this as a PDF to the FDA through our electronic submissions gateway. These PDF files are individually stored in an eCTD file folder structure format, and then hundreds of clinical reviewers, real people at the FDA, physicians, pharmacists, and nurses, must manually click through the thousands of reports submitted per year, review them to identify if any regulatory action should be taken, and then track this safety information over time in whatever system that they choose to use, Excel files, sticky notes on their desk, or any other decentralized tracking system. Each of these steps takes time, adds inefficiencies, and creates challenges for identifying and tracking potential safety information from patients and clinical trials. Next slide. In the new submission process, drug companies will generate an XML file directly from their safety databases using an international data standard called ICH E2B, and then send this file to the FDA's Adverse Event Reporting System, or FAERS. While we are working with an AS2 exchange process right now, we plan to upgrade this to an API in the future as we develop subsequent details of the system. FAERS will house IND and post-market safety reports that use the same data standard, and FDA reviewers will then be able to take advantage of new tools to review and track this structured data. And shown here is an example from the FAERS public dashboard to illustrate the types of analytics that can be done, including visualizing the types of adverse event reports about a particular drug. This really allows us to have a scalable process looking for safety events across those 30 to 50,000 IND safety reports submitted per year. Next slide. During the implementation of this process, we encountered our share of challenges, but also identified opportunities for improvement of this process and other FDA processes. For example, with respect to data standards for our program, we felt it was important to use existing international data standards as drug development is a global endeavor. However, these standards did require some modification in order to meet specific FDA regulatory requirements that differ from other agencies around the world. Therefore, we conducted a pilot program of this new process with industry in order to assess our program and capabilities and to dialogue with industry to understand how their current processes work and to try and limit the impact on all these different stakeholders. Second critical element was infrastructure. And regarding infrastructure, we were able to use existing FDA systems like the FDA Gateway, but we needed to connect and harmonize existing disparate FDA systems for processing these files, including appropriately coding investigational drug names and routing to the appropriate FDA review team, and also to adopt new tools for regulatory review and analyses. And finally, as I mentioned, the current AS2 exchange process is the MVP, the minimal viable product, and we're exploring new data exchange pathways, including APIs for more efficient and secure exchange of safety data from a variety of sources in the future. Importantly, security is paramount to us at all times. The last thing I wanted to mention was change management. These processes impact an entire industry, a huge industry that's worldwide, and also our public health as a nation and our work at FDA. We needed internal training, new SOPs, external guidances, webinars, conferences, and all different ways to disseminate information about what we were trying to do as a part of this new process. Though I focus today on 7 and 15-day IND safety reports, we have similar data modernization efforts going on all across the agency, and we're learning from this one in order to implement those other API-based data exchange efforts for the future. Thanks, and appreciate the time.
Thank you so much, Amy. And we are going to turn it over to Director Khanna from AHRQ. Take it away, Director.
Thank you and good afternoon. We live in a digital age. New tools and devices are accelerating the generation of and collection of data like never before. The amount of information flowing through the system is truly astronomical. As a result, healthcare experts require new tools and resources that utilize data to have a deeper understanding of the patient and create transformational change in the healthcare quality, safety, and value. I'm really pleased to be here today to discuss ARC's growing portfolio in digital healthcare research and how we are contributing to the acceleration of APIs in healthcare. To help achieve truly Secretary Alex Azar's vision of improving the health and well-being of all Americans. Recognizing the explosion of data and technology, I've challenged my staff to think differently about new demands of patients and healthcare providers in order to help facilitate the transition from traditional brick and mortar system of healthcare delivery into delivery of care in the digital age. This means rethinking healthcare delivery across the care continuum from preventive to palliative care. You see, cure and care are two sides of the same coin. And in order for us to fully realize the value of our investments in biomedical research, we must make sure that cures and therapies translate into healthcare delivery that is safer, higher quality, and of higher value. To do so, ARC has embarked upon what we refer to as our 21st Century Care Initiative to help make sure 21st century cures translate into 21st century care. The goal of our 21st Century Care Initiative is to fundamentally change the way health services and primary care research is conducted and used in the United States. We want to produce evidence more quickly in a way that is rapid cycle, scalable, and usable at the point of care. We are creating new opportunities for researchers through innovative grants, challenges, and partnerships. And we are unlocking new possibilities for data science developers by substantially increasing our data and analytic capabilities, including through the integration of new supply-side, synthetic, and social determinants databases. As I mentioned, healthcare providers and delivery systems have become inundated by the sheer volume of data flowing into the system and out of the system, leaving much to be discovered about best practices for the use of digital health technologies. ARC has made it a goal to be the lead federal agency to answer these emerging questions. And to do so, ARC established a new division of digital healthcare research in January of this year, led by Chris Demick, who joins us today. This division aims to produce rapid cycle research and evidence-based tools to support 4 strategic pillars that are critical to providing 21st century care. And they are health equity, optimized care delivery, evidence-based practice, and engaged and empowered patients and caregivers. I'm extremely proud of Chris and her entire team for the brilliant work they are doing. 2 years ago, ARC made a commitment to move forward with a forward-thinking API strategy. In 2018, through CDS Connect, ARC released an open source Smart on Fire app that acts like a dashboard within the EHR to help clinicians easily understand a patient's pain history, pain-related medications, and pain assessments. This capability is of critical importance as the nation continues to face the opioid crisis. Over the last year, we have built on that pain management summary by enhancing the dashboard and by giving patients the ability to view their data and report how they are doing through the patient portal. And recently, we built a prototype of the pain management summary that incorporates data from prescription drug monitoring program, which we know clinicians consult when considering medications and other therapies for managing chronic pain. Additionally, we have launched a new project called CEDAR, which aims to make ARC evidence accessible through APIs so that innovators, developers, and others can put evidence at the fingertips of clinicians, patients, and care teams. This is yet another example of how ARC is making its research more available and usable for the innovator community to meet the needs of health systems executives. You see, if you're a health system executive, you don't want to hear that somewhere some evidence exists that can improve healthcare quality in your hospital. You want tools and resources that do the heavy lifting for you, that you can quickly put in place right now. That is the goal of CEDAR and the Division of Healthcare Research as a whole, to recognize the enormous potential of utilizing APIs to bring research and evidence directly to clinicians, to make sure that improving healthcare quality is easier. Today, I'm also really excited to announce the winners of our Digital Solutions to Support Care Transitions Challenge competitions. ARC hosted this two-phased challenge competition to solicit ideas for digital solutions that reduce burden in care transitions for individuals living with multiple chronic conditions. And you've heard a lot about that with the COVID-19 crisis. People with underlying conditions are hugely impacted. Winners for phase 1 were announced in June. In phase 2, teams developed their proposed solutions. Winners were chosen based on the solver's ability to understand the problem and create a user-centered design, how well it met the needs of patients and providers, and its technological innovative approaches that they can take, including its ability to leverage FHIR interoperable standards. And now, ARC is excited to congratulate CareLoop, who will receive a $50,000 first prize, as well as Vival.life, who will receive the runner-up prize of $25,000. By the way, this is not our first time conducting challenge competition, and nor will it be our last. We launched our first challenge in August of 2018 at the Blue Button Developers Conference with our Step Up App Challenge, and we are just now wrapping up our 5th challenge, Innovations to Improve Rural Postpartum Mental Health. Now, this challenge is looking for and program proposals that provide success stories to address growing issues surrounding postpartum mental health diagnosis and treatment in rural communities. This challenge is especially important in light of COVID-19, which has totally disrupted the healthcare system and exacerbated mental health issues. We will soon be announcing the winners of this challenge as well, so please stay tuned. Now, please be aware that ARC intends to continue its work with challenges, and we hope to announce at least 2 additional challenges soon enough in FY 2021. Finally, ARC will be announcing later this month 29 COVID-19 related grants with funding totaling up to $17 million. ARC will fund critical research on topics such as effects on quality, safety, and value of health systems, response to COVID-19, the role of primary care practices and professionals during the COVID-19 epidemic, how the response to COVID-19 affected socially vulnerable populations and people with multiple chronic conditions, and implementation of digital healthcare, including innovations and challenges encountered in the rapid expansion of telehealth response to COVID-19. All applications are expected to be funded prior to January 1st, 2021. In closing, I want to re-emphasize ARC's focus on expanding our digital healthcare portfolio as an important component of ARC's 21st Century Care Initiative. And I want to stress the importance of engaging with the digital healthcare innovator community moving forward to build upon our API strategy in fiscal year 2021, in calendar year 2021. And thank you all.
Thank you, Director Khanna. All right, we're going to go to Jude Soundarajan from the Social Security Administration. Take it away, Jude.
Thanks, Steve. I guess if I were my name is Jude Soundarajan. I'm the Executive Director of Health IT at the Social Security Administration. I just want to thank you, Steve, and Dr. Rucker and Elise on all your work on our behalf in advancing health IT. I know if my bow tie was fire enabled, it'd be much easier to tie in that same vein. I hope just great for all your work in fire APIs. So let me give you a little background on SSA. So we do all the disability determinations for the country. We do about 3 million claims per year, and we collect about 14 million medical records per year. So we're one of the largest users of medical records, albeit outside the treatment case. And out of those 14 million records, only about 2 million are electronic, that good, rich health IT data. The rest is unfortunately in that legacy formats, paper and fax. So we're pushing hard to move that to health IT and eventually to resting APIs. So we launched our health IT program back in 2009. It's been a great success. It avoids delays to our claimants and lets us do these claims very quickly. And so we connect with over 200 health systems, which equates to over 20,000 healthcare facilities. And it's just been a great help to our adjudicators to make quicker and more accurate decisions with that rich electronic data. So looking ahead, we want to accelerate our use of FHIR APIs. And we want to enable FHIR APIs throughout our health IT partner program. And we want to look at how we can enable our claimants to provide their data to us through online access through FHIR APIs. To that, we've launched a proof of concept. That proof of concept is express medical evidence. And we use that to validate the potential of open APIs and FHIR to help us make more accurate and timely disability determinations. All that being said, SSA has a need for a complete record, and that complete record includes all of the clinical notes and the sensitive data. So we are working to test the US CDI data with our agency partners and health systems, and we will use that testing to make recommendations for future enhancements to US CDI to encompass those clinical notes and sensitive data. So we appreciate all of the work that CMS and HHS ONC have been done to advance resting APIs, FHIR, and we look forward to leveraging this in our disability application process. And so we intend to explore all options in enabling FHIR APIs to streamline our benefits applications. And so that would include enabling FHIR throughout our HIT partner network, perhaps even with a direct-to-consumer portal that will allow us to ingest data directly from the consumer. That would be a huge breakthrough for us. So these are very exciting and innovative times at SSA, and we invite your participation in our work in testing these FHIR APIs. And I'd love to hear from anyone who wants to connect with us through FHIR APIs. Our health system wants to connect with us on health IT. So please reach out to me. So in closing, I just want to thank HHS ONC on all of their efforts on our behalf for pushing interoperability in our country and continue to work in collaboration with our agency. Thanks, Steve, and thanks, ONC.
All right, thanks, Jude. Thanks for keeping us close on time. I'm going to turn it over to Paula Braun, and she may be joined by Laura Kahn as well to do another round on CDC updates.
Great, thanks, Steve. As you can imagine, in order to track and respond to the evolving COVID pandemic, we need up-to-date information on cases. And while we typically think about the challenges associated with public health reporting, I can say that when it comes to getting information on COVID patients, one of the exciting things is the fact that we no longer have to send people to a healthcare setting in order to get tested. There are point of care testing sites that have emerged across the country. And as Amy mentioned in her introductory remarks, many of these partners who are providing these tests are new to public health reporting. They've never done it before. They have needs that are unique to our traditional lab and healthcare setting partners. And so what we've done working with the United States Digital Service is to develop a tool called Simple Report that makes the process of reporting to public health simple. And so it is a basic web application, and I'll go ahead and start sharing my screen now so you can see it. And what it does is, you can imagine if you're a nursing home administrator, or you're working at a school or some other congregate setting like a jail, you'll have patients that you need to test over and over and over again, or residents or community members that you need to test over and over again. There's also information that you'll have to enter about your facility. And so what this report does is it gives you the opportunity to enter all of that information once, as well as the different types of point of care testing sites or point of care testing devices that you use. So that way you don't have to re-enter that every single time. And for the people who are part of your facility, you can have them here. And so when it comes time for you to test somebody again, I happen to know that Alexander Hamilton is one of our residents at the nursing home where I work. And so today he's asymptomatic, but he was exposed to someone who we think may have COVID. So we want to test him as well. And so we'll say, no, this is not his first COVID test. He actually was tested yesterday. So we can go ahead and enter all of that. And the type of COVID test that he had before was an antigen, and the result of it was negative. And we don't believe that he's pregnant. And so we'll go ahead and just add him to the queue. And I can select what it is, the device that I'm using for the day, because we know that while the manufacturers of many of these devices have solutions that are unique to those devices, many of the settings are just using by hook or crook any of the testing options that are available to them. So in this case, we're going to use the BD Veritor, and I can go ahead and run the test and then just say, okay, he's negative, and then off the test will go. It'll get sucked into the data hub, and it will make its way to both state and local public health departments, who are the authorities to whom we need to report this information. And it's really just as simple as that. And so if you're interested in learning more about it, you can go to simplereport.cdc.gov. And now I'll hand it over to Laura.
Thank you, Paula. First, I'd like to start by thanking HHS and ONC for hosting this event that will allow me to share how we put critical electronic case reporting technology in the reach of all electronic health records by using FHIR APIs. Electronic case reporting, or ECR, is a critical public health initiative that automates the submission of case reports using existing data from electronic health records and sends it to public health agencies for review and action. Reporting by healthcare providers of conditions of interest to public health is mandated by law in all states and territories in the United States, and automating this process will reduce the burden on healthcare providers to fulfill these mandates and provide more timely and complete data to support critical public health functions such as case management and contact tracing. Despite having electronic case reporting as a public health measure in the CMS Promoting Interoperability program, at the start of the COVID pandemic, very few EHR vendor products had developed the capability to implement ECR. In January, when COVID-19 became a reportable condition to public health, only a few implementations of ECR were in place. However, it was clear that ECR is a critical function to provide data needed by public health for decision-making during this pandemic. ECR is being operationalized by the Association of Public Health Laboratories, the Council of State and Territorial Epidemiologists, and the CDC. Next slide. This group conceptualized and launched the strategic initiative of ECR Now to rapidly advance implementations of ECR for COVID-19. We'll focus on the second element here of this initiative of the FHIR is the ECR Now FHIR app. And because of the Fire API, we were able to convey ECR reporting technology to electronic health records that did not have it. Next slide. Focused on element 2. The app has been made freely available to all, along with the source code. The app was developed to take advantage of the Fire APIs that should be in place in healthcare today. It uses queries in DSTU2 and R4 and runs in the EHR inside the healthcare organization. The app ingests the electronic reporting and surveillance distribution package that's provided by public health and provides the trigger codes and the trigger timing specifications to operate against the data in an encounter in an electronic health record. It is intended to work consistently and automatically without disruption of the provider workflow, and is launched in the background at the start of every encounter, either using Smart on Fire provider app launch or a system launch. The app executes queries to look for possible triggers in the patient record at specific times. 1 hour after the start of the encounter, which allows some time for data to be entered in the record, and then every 6 hours following the first query throughout the encounter. Once a trigger has been identified or matched, additional queries are executed to pull the data needed to populate the electronic initial case report. The EICR is then pushed from the app to the APHL AIM shared services platform to process and route those case reports to the appropriate public health agency or agencies. Additionally, once a trigger is identified during an encounter, an updated case report will be sent every 24 hours for the duration of the encounter, as well as a wrap-up report 24 hours after the close of the encounter. For every electronic case report, a reportability response is returned to healthcare from public health to confirm reporting and provide information to clinicians about the condition in the context of their patient. At the start, the ECR Now Fire app will output an EICR in CDA format in order to meet public health agencies' current capabilities. Today, public health agencies do not support Fire operationally. However, the app can be configured to send Fire reports when public health is ready. Transforms between Fire and CDA are also available so that as transitions to Fire occur in healthcare or in public health, all organizations can get what they need. While the current focus is on COVID-19 electronic case reporting, the app is also configurable to accommodate reporting for all reportable conditions for those healthcare organizations and public health agencies that are ready to expand beyond COVID. Providing ECR Now Fire app for all electronic health records to use meets the industry where they are from a technology capability, doesn't require new development in their products, and allows for implementation of ECR for COVID now. Thank you.
Okay, next we have coming up Gil Altaveritz with the Veterans Administration. Gil, why don't you go ahead and while we wait for Steve to get his Zoom back online, go ahead and jump into your presentation.
All right, very good. So today I'll be talking about the AI Tech Sprint, which is and empowering patients through the AI Tech Sprint. This is part of the National Artificial Intelligence Institute in this joint effort between the Office of Research and Development and the Secretary's Center for Strategic Partnerships. So when we think about the VA, it's actually the largest integrated healthcare system in the country, and it has over 9 million patients. There are 10 billion images, 1 billion kind of generated each year. A lot of information that is available to help in our mission of working and serving the veterans. More than nearly 3/4 of all U.S. doctors and nurses are actually trained in VA hospitals before some of them end up working elsewhere. So there's really a great potential to learn, use this information for our mission. And so the idea with the AI Tech Sprint, which is just one of a number of different efforts going on, of course, at the VA, but which is, as you'll see in a minute, has led to a number of these apps and applications that use these APIs, is that the AI tech sprints really enable this nimble approach for enabling innovation and paving the way for future partnerships. So the idea is to have a sprint, which is about 3 months, and to be able to then engage and foster collaboration with industry, academic, nonprofits, others, along with input from VA researchers and clinicians to iteratively design AI-enabled tools that leverage federal data, which could include APIs, as we'll see, to address needs of the veterans. I'm happy to announce here that we're going to have $100,000 in prizes for this year's AI Tech Sprint, which will begin shortly. The theme is around interventions for veterans not currently being served by the VA. And the time for applying is by December 16. And that's just to basically submit an application to get started. Then there's 3 months to actually build and create a potential tool or add a new module to an existing tool, and they'll start January 4th. And I'm pleased to say that the challenge, or this sprint, is now live on challenge.gov, and there's a link here, or you can search that online. And then there are going to be data sets and APIs available from the VA, including through different data use agreements, but we also encourage people to bring your own API or data sets as well. So let's take a look at just what happened in this past year in the AI Tech Sprint to show you what I mean, and an example of the kinds of breakthroughs that we've seen by partnering and working together. So just as an example, non-adherence to medications can really account for 50% of treatment failures and around 125,000 deaths and a number of different hospitalizations across the country. So one of the participating organizations created a module for this environment called Cure Patient, which, as you can see here, actually will take a look at you holding a pill in your hand or wherever the pills may be, and it maps it onto, it leverages, we heard before the speaker from the FDA, Dr. Amy Abernathy, it leverages that API to see what medications you have, to recognize the picture using machine vision. It leverages the VA API to see what medications you may have. And it uses census data to improve health equity challenges around a number of different aspects as well. It was actually the winner of the Future of Health in a national competition. And it's estimated that this would also, as another benefit, save practitioners' office time by around by 4,900 hours a year in terms of phone calls dealing with these types of questions about medications and when to take them and so forth. So we're excited about this result. We actually recently had a request for information. I've been working on developing a contract, a vehicle around this, using this novel approach of having this national competition to work toward contracting. The other thing that I'm pleased to tell you about really is this idea of empowering over 9 million veterans and 50+ million CMS beneficiaries to find clinical trials, whether it be cancer, COVID-19, or other areas. This was actually created by, as part of this AI Tech Sprint as well, with the Girls Computing League. And just to show you a really great example of students stepping up. This was actually the only student team, but that student team was recognized also in a national competition for building this. It uses the VA and CMS APIs, and I'm pleased to say it's now using production, has production access to that data. So upon consent of a veteran or CMS beneficiary, they can actually log in, get that information from their health record, and that is used to actually look for the different trials that match them. It also leverages the National Library of Medicine API, UMLS, and National Cancer Institute's clinical trial APIs, among others. It's, as far as we know, the only application that leverages all those APIs together in an integrated way, and it's now available in the VA app gallery that recently came out as one of the first 5 applications there. Here we're going to just see kind of that integrated view of where basically a patient, if they're a veteran, they may have a VA account, right, and they're logging into that. The same patient may also have a CMS account, especially the older patients. They'll end up transitioning or using part of their benefits through CMS, so they can log into both and use that information. In this case, we're using the sandbox for privacy reasons, but as I said, it's open to production level data and has been, and a number of veterans have leveraged it. And so here you'll see the trials that match up the conditions that that patient actually has. So another great example there of something that has been created. And so with that, I really want to just leave you with kind of our contact information and information if you'd like to apply and or to join the AI VA community, which is looking around cutting edge AI research and development and in implementing these kinds of programs. So thank you very much, and I'll pass it back then.
All right, thanks, Gil. And double mute was the death of me at this point when Zoom decided to restart on me, which is a 21st century problem. So with that, I will turn it over to our colleague at the NLM, Dr. Patty Brennan.
I'm trying to get my screen to share. Steve, Kanya, can you let me have the screen? Good afternoon, everyone. This is Patty Brennan. I am invisible because the host has muted my video. Let me tell you, as the director of the National Library of Medicine, I'm really here to speak to you about the National Institutes of Health interest in FHIR. NIH is a research agency, as you're well aware. Our motto is to transform discovery into health through 27 centers and institutes. We spend about $35 billion a year in research in the extramural community. That's around the country. NIH is committed to the concept of precision health, and precision health requires research informed by care processes. So our vision is to enhance the research at the NIH through the effective use and access to and use of clinical information. However, as you all know, this is challenging. Across the bottom, you see the trajectory of data that we'd really like to see happen. Phenomena gets translated into some type of clinical terminology and organized within the US CDI, and using the FHIR standard, it's ultimately transferred into a research record. We know, though, that care is given in a number of different systems, and so to promote the integration and reuse of data collected during the course of clinical care, and also to make data available from a single study useful across studies, we need to make sure that that research data has the same level of organization of the clinical information as we expect in the clinical area. To take this step into operation at the NIH, we first issued in 2019 a guide notice that alerted all investigators that the NIH is encouraging the use of the fast interoperability FHIR resources to capture, integrate, and exchange data from the clinical area for research purposes, and also to enhance our capabilities to share research data. The NIH really plays 3 key roles in supporting researchers to use FHIR and FHIR APIs for research. First, we establish policy. That's what you see in front of you. Second, we develop a mechanism for ensuring that we're demonstrating how to use this. We fund various tool building activities. And third, we actually fund research in the use of FHIR and the development of new FHIR tools. There are 2 projects underway right now that would be of interest to you. The Phenopackets on FHIR, which is an attempt to build a FHIR implementation and guide that's informed by the Phenopacket standard. So this is a way to get phenotypes expressed in the clinical record and aligned with genotype information. The second is we're supporting Vanderbilt to extract clinical data for research using a REDCap extension. Both of these projects are underway. Their toolboxes are available. I have sites on the slides you can see when you see these in the email. The other thing that the NIH is doing through the National Library of Medicine is demonstrations. And so we're developing various tools that can be used, can be experimented with and downloaded by different groups. So here you see an example of the Lister Hill Center's flow sheet on FHIR, which is a tool used to monitor specific patients over time. It pulls many observations from a fire server and then organizes them with a customizable data dictionary and hierarchy template. There is a demo available for a particular patient, Ahmed Aziz, and using the URL that you see on the screen, or you'll be able to pull from the slides, you can explore this. We have a few other examples of fire applications that have been useful and built by our Lister Hill Center team. One is the Fire Research Data Finder. This is an example of trying how we might capture common data elements, a type of language standardization through research. And here would be a form that allows you to pull from a server using a specific set of codes and retrieve a suite of patients identifiers, as you see at the bottom of the list. This can support the development of cohorts for study. It can also support investigations to determine whether or not there's sufficient patients available for new research studies. A third example that I'm showing you is a questionnaire that allows for pulling together specific information about a single person. This, in the case that you see in the screen in front of you, this would be one that would have been developed for a drug toxicity panel to understand the effects of a particular drug, to pull information from the clinical record and allow it to be used by researchers. NIH is looking to the future with a number of different enhancements. First and foremost, we are approving and improving our VSAC, our Value Set Authority Center, with a fire implementation. For those of you unfamiliar with VSAC, Value Set Authority, this is a cooperative activity between the ONC and the NLM to create clusters of identifiable codes to express critical patient phenomena useful in both billing as well as in quality management. For example, a patient with diabetes or a person with COVID, pulling together the codes that are necessary to describe that. Putting that VSAC on fire will enable this to be better used for clinical research. We also are looking to extending applications for research and technology development. We have 4 SBIRs, that's Small Business Innovation grant opportunities, that are available now for building fire tools. We expect to continue to release those innovation incentive programs. We also are writing the fire expectation into many of our new research funding opportunities. So there's tremendous opportunity here for using the research data, using clinical data for research. Finally, we're very excited about the use of smartphones and the fire standard being able to extract data to pull information experience in everyday life. We realize that health occurs not only in the hospital, but also in patients' everyday living, and the extent to which fire APIs can give us a window into those lives of patients will be particularly valuable in the research in the future. So in summary, the National Library of Medicine provides access to, development of, and funding for fire tools that enhance the use of clinical information, be it generated in the clinical setting or by the patient herself or himself, for the purposes of research, and also to extend research results across multiple studies. Thank you, and good luck with the rest of your conference.
All right, thank you, Patty. Thank you for your partnership with ONC. So we've reached that point of time when we're going to give everybody the 7th inning stretch. Stefan will stick around to sing you Take Me Out to the Ballgame. And we invite you to come back at 2:40 Eastern time. We're going to just make it a clean time break right there. So see you in a few minutes. All right. Ready to kick it off, Stefan. We use the NTP synchronized NIST clock for our timing here at ONC. Gotta throw in a standards joke for everybody. So welcome back. That was a quick few minutes. We are going to get back right into it with more presentations from our industry partners as part of this segment of the API Showcase. A reminder, we have the hashtag ONC API, as well as the ONC handle, ONC_Health IT. We're going to have a number of presentations and demos. So just like with our federal partners, I don't want to say that they hopefully they won't put you all to shame, but certainly make sure that, you know, as you do your screen sharing, stop screen sharing, video on and off. We will keep going ahead at pace. I want to thank everybody for their continued cycles through. And in the spirit of industry collaboration, we do have a tweet-worthy announcement on the ONC side. I am pleased to let folks know we are engaging in a new collaborative project that we are referring to as Project USA, which stands for a unified specification for address in healthcare. Address is one of the data elements in the United States core data for interoperability. And across industry, it is an element that is used in many of the transactions that occur largely in the clinical and administrative domains, and especially as you look to link patient records together as well as conduct patient matching, address is one of those core elements for the work. So over the past several weeks, we've had discussions and got commitments from our colleagues in the SEO community to make this an industry-wide activity. So cross SEO, and many of them are part of an organization that you're probably not familiar with. It's just called the Health Standards Collaborative. I'll be putting out a blog post today that will have a bit more details. But again, the focus is going to be on addressing this address problem once and for all. Puns are always included with my presentations. But key partners, HL7, NCPDP, X12, the rest of the standards family that's part of the Health Standards Collaborative, among other healthcare standards leaders. Others are going to be welcome to join. We're going to launch this right at the early stages of 2021, and this is a completable project within the year. So that is going to be our driving focus, and ultimately will result in a specification that across all of the SEOs and any other accompanying users in the healthcare space, we can have a single and consistent approach for how we detail out and represent address. HL7 is going to be providing the project management and will be a home base from a digital perspective on the web, but more to come. And wanted to let everybody know that this was going to kick off the year right at the beginning. So as we transition to our industry-led activities, wanted to make sure that we had an opportunity to highlight all the progress that's been made this year, other ways in which our industry colleagues have been both burning the candle at both ends in terms of patient access and access to healthcare data, and then provider-related tools and usage of Fire-based APIs. In this case, one metric that would be helpful just to set some context. Many of you may know that in 2019, the Promoting Interoperability Programs, as was discussed earlier, was the first year in which 2015 edition technology was first required. That, if you recall, our 2015 edition at the time, before our 21st Century Cures rulemaking, did not require a specific API standard, but a lot in industry went forward to adopt Fire anyways and have largely deployed Fire as their API of choice to meet that earlier version of the certification criterion. And so of the participating healthcare providers in the Promoting Interoperability Program, you have 96% of hospitals and 94% of clinicians that have participated in the CMS PI program that reported using 2015 edition technology that supports a Fire-based API. So largely ubiquitous. You're going to have trouble for any of those hospitals or healthcare providers that are participating in the CMS PI program, bumping in any one of them that isn't using Fire. So that's going to really, I think, set the groundwork for, in the context and surround ultimately for all the presentations that you're going to see later, is leveraging this new foundation, this new ability to connect via Fire-based APIs, both on the patient side and on the provider side to enable better tools for our healthcare providers. So we're going to dive right into the first session as part of this second segment called Doubling Down on the Consumer App Revolution. We have a number of our colleagues from the app and mobile community and as well as a case study to really bring it all home. So I'm going to turn it over to my colleague Ricky from Apple, and he will take it away. Hey, Ricky.
Hey, Steve. Thanks so much. Let me share my screen here. All right. Excellent. So I'm Ricky Bloomfield, and I lead our clinical and health informatics work here on the health software team at Apple. And I'm super excited to give you an update today on how our work with the standards community has helped accelerate the adoption of interoperable technologies through health records on iPhone. So we started our journey in 2014 when we released a health app on iOS, which makes it possible for users to securely and privately store and share their health data. In 2018, we released health records on iPhone, which gives users the ability to download their health records directly from their provider using the Smart on Fire set of standards. So here you can see how users can look up a health system they've gone to. Say, for example, they choose UNC. To get their health records on their iPhone, they then use their UNC portal credentials to authenticate. Then they can see all of their health records from multiple providers together in the same place, ready when they need it. From the beginning, the health records feature was designed to protect user privacy. Apple's enabling a user to request and download their health records through a direct encrypted connection between the user's iPhone and the health organization. Neither the user's records nor their credentials traverse Apple's network. The data is encrypted in transit and also on device if the user's iPhone is either password protected or protected with Face ID or Touch ID. This means the user is always in control of their data. And of course, Apple is not creating, receiving, maintaining, or transmitting PHI for and on behalf of a covered entity or business associate as part of this process. With iOS 12, we introduced the ability for a user to choose to share their health records with third-party apps. Given the increased sensitivity of the data, we built in a number of additional privacy protections as part of the sharing. First, we make it clear to the user that it's important to trust any app before they give it access to their health data. The data is then sent directly to the third-party app on device and is not visible to Apple. Second, the user controls which categories of data they'd like to share. They're also encouraged to review the app's privacy policy. A privacy policy is required for all apps in the App Store. And lastly, by default, apps have to ask each time before they can access any new health records data. Users can choose to automatically share new data if they trust the app with that information. And one last note, any app that requests access to a user's health records must adhere to some additional requirements and goes through a special App Store review process. For example, these apps are prohibited from using the health data for certain purposes like advertising or marketing. So how's it going? Well, we announced health records on iPhone in early 2018 with 13 health organizations representing 3 different EHR vendors. We now have over 600 participating health organizations, many of which have quickly and easily enrolled using our self-service portal. This represents over 11,000 unique locations for the US, UK, and Canada. And we've now grown to 10 supported EHR vendors and organizations with even more on the way. And of course, all of these organizations and locations support the Smart on Fire set of standards. Just this fall, we announced that health records is now available in the UK and Canada, making healthcare data interoperability an international phenomenon. And one last note about interoperability. As many of you know, it's about much more than just the data format. It's also important to have a deep understanding of healthcare terminologies such as LOINC that add meaning to the data. So when the health app receives coded FHIR data, we're able to take advantage of these terminologies to create a better experience for our users. This includes user-friendly display strings for labs and vital signs that you can see on the left, as well as the ability to chart data together that's come from multiple disparate sources. And this work has only been possible because of the tireless efforts of the healthcare standards community, many of you here on the phone today, and I believe we're truly standing on the shoulders of giants with this work. And of course, we look forward to continuing to work with all of you to empower patients to access and meaningfully use their health data. Thank you very much.
All right, thank you, Ricky. So we are going to turn it over to JP Pollock from CommonHealth for a bit of an Android update, I'll call it, for lack of a better word. And then JP will be followed by Dr. Adam Landman from the Brigham Women's Hospital, as well as Josh Good from the Scan Health. So I'll turn it over to you, JP.
Great. Thanks so much, Steve. So I've spent the last 20 or so years working in mobile health and digital health. And to be honest, much of what we've promised over that time frame hasn't really come to pass. The reality is that most of the innovative digital health applications that we've imagined have been starved for data. This is data about behavior, data about context, data about a person's clinical history and status. We've gotten really good at the first two over the last decade or so, but only now, thanks in large part to the work of ONC, are we beginning to tap into that third. As you just saw, Apple has done amazing work over the last 2+ years giving people access to their health information securely and in one place. And there are several other really great personal health record apps spanning iOS, Android, and the web. This is why I'm here today to talk about CommonHealth. With colleagues at Cornell Tech, UCSF, Sage Bionetworks, we started CommonHealth out of a belief that the ecosystem needed parity, an open source Android complement to what Apple Health is doing. This parity is important for people. It's important for providers looking to encourage patients to take control over their health. It's important for developers and researchers building digital health apps and services. And it's important for equity. CommonHealth, much like Apple Health, helps people download records securely to their device directly, store them only for themselves, or share those data with consent with trusted apps and services running on their phone. We've taken time getting this model right. With Ida Sim and collaborators at UCSF, we've done extensive user research and testing in diverse populations throughout San Francisco to ensure that people get value from CommonHealth and that the equitable access we're pushing for is in fact equitable. We've worked closely with providers, including early partners like Mass General Brigham and LabCorp, to make sure that every detail on the data we present is right. And we extensively QA each new provider that we bring on board. As we work on future functionality, like support for pediatric records, we work with domain experts like Natalie Pagler and Stanford Children's. And we do participatory design work to get as much as we can right out of the gate. To address the challenges of sharing data with third parties, how do we gather informed consent from people? How do we protect their data? How do we decide which apps and services get to connect and keep those developers accountable? We've worked with key stakeholder groups, including patients and patient advocates, providers, privacy and security experts, ethicists, app developers, regulators, and industry coalitions like Kare. And by operating CommonHealth under the Commons Project, a 501c3 nonprofit, our interests are fully aligned with those of CommonHealth users at all times. I'm really happy to be able to update you all today on our progress. CommonHealth is already a great experience for owners of Android phones, connected to over 200 health organizations with integrations to all of OpenEpic and other key institutions to be completed this year. CommonHealth is a developer-friendly platform that works similarly to Apple's HealthKit, and digital health innovators and app makers could even use a Cordova plugin and write just one set of code for both iOS and Android. We're really excited to get this underway with the developer community. We're working with health plans like SCAN on several different types of initiatives. Of course, those include getting people access to their claims and related information. Josh will be speaking about one such initiative in a bit. We're working on with OpenM Health on standards-driven ingestion of wearable and other mobile health data, and we're looking forward to talking about this very soon. Finally, because it's 2020, we're doing what we can to help people through the pandemic. The sharing of COVID test results and ultimately vaccination records seems like low-hanging fruit for an app like ours, but the personal health record model has authenticity issues when it comes to these kinds of data. We're working to give people a way to present signed health data to verifiers such as employers or airlines and have those data be trusted. We're working with Josh Mandel at Microsoft and several technology and care providers to implement the Smart Health Cards framework into CommonHealth, which leverages the W3C verifiable credential standard to do this. And with that, thank you all, and please don't hesitate to reach out with any questions.
All right, thank you, JP. Let's move on to Adam from Brigham and Women's. Take it away, Adam.
Thanks so much for the opportunity to talk with you today. I'm going to build upon the previous presentations, first telling you a little bit about our health system and why we implemented patient-facing FHIR APIs, and then I'll share our experiences and next steps. And I'm speaking on behalf of the many team members at Mass General Brigham who made this possible. Briefly, I'm an emergency physician and the CIO at Brigham and Women's Hospital, part of Mass General Brigham Healthcare System in Boston, which is formerly Partners Healthcare. And as background, we use the Epic EHR throughout our organization. So first, a little background, why did we implement patient-facing FHIR APIs? And first, we believe giving patients access to their own health data is beneficial for better patient engagement, enhanced care coordination, and improve patient safety, to name a few reasons. And it's also required, of course, by the HIPAA privacy rule and the 21st Century Cures Act. Mass General Brigham has a good experience now, has a good amount of experience now with patient-facing APIs. We first went live with Apple's health records on iPhone in February of 2018. We also participated in the Sync for Science pilot. This is a collaboration among ONC, NIH's All of Us research program, and the Harvard Medical School Department of Biomedical Informatics. And this enables patients that want to participate in the All of Us research study to share their EHR data using FHIR APIs. And most recently, and very imminently, we are pleased to share that we'll be going live with the CommonHealth Android application for MGB patients. Fortunately, our EHR vendor provided much of the technical infrastructure to support the requirements of implementing patient-facing FHIR APIs. But we have learned a lot in this process, and I just want to share just 3 lessons learned. The first is this is a major paradigm change, and I personally may not have appreciated this as much, but it really did require educating our providers and our health system leaders about this functionality and requirement, and more so than I anticipated. Secondly, you can't just turn this on. It requires, as with all health IT and digital health solutions, it requires us to do data element review, mapping, and testing to ensure that our EHR data is correctly represented in the APIs. And finally, this is not available to all patients. Actually, to access the APIs requires patients to have a patient portal account, and we know that there may be some equity issues here. I also want to share that there have been very few academic studies on FHIR API use. Under Dr. Will Gordon's leadership, we have sought to better understand the characteristics of patients that are connecting apps to an EHR using APIs. We actually looked at our data across the MGB system for about a 1.5-year time period, looking at patients that had authorized an app to use the FHIR API. And we compared those patients against a control group of patients who used our patient portal and accessed our patient portal on a mobile device, but didn't use APIs. And we compared these groups using multivariable logistic regression. And what we found is that overall, actually a very small percentage of our total patient portal users were actually using FHIR APIs, about 1%. So about 10,000 out of 1 million patient portal users were actually using APIs to connect to apps. We also identified characteristics associated with an increased likelihood of being an API user. And those include male sex, younger age. Asian patients were more likely to be API users than Black, Hispanic, and white patients. And English-speaking patients were more likely to be API users than Spanish-speaking patients. So overall, we are really excited now to have both iOS and soon Android apps to enable patients to be able to access their data using FHIR APIs. And there's an opportunity for us to increase awareness of this functionality to both our patients and our provider community. Secondly, we think there's an opportunity to increase the number of high-quality apps that make use of these FHIR APIs. And importantly, find more apps that can develop multiple languages supported beyond English. And finally, as JP noted, we're excited to work with CommonHealth and other stakeholders on standard digital credentials using FHIR for COVID-19 vaccines. Thanks so much for the opportunity to share this with you.
All right, awesome. Thank you so much. And we're going to turn it over to Josh from SCAN Health to wrap it up.
All right, thank you. Thank you, Steve. Josh Good, CIO of SCAN Health Plan. I want to spend a few minutes talking about the interoperability provider playbook that we are developing in partnership with CommonHealth. So SCAN is a Medicare Advantage plan, Southern California. And one of the things that we noticed across our provider network, a lot of variance in the understanding of the interoperability regulations, whether it's with a larger health system or with our IPAs. Second slide there, Steve, slide 48. All right. With our individual IPAs, a wide variance of the understanding of the interoperability regulations. So, what we looked to do to fill the gap was we wanted to develop a easy to read playbook that really summarized what are those regulations. So this is not a 50, 100-page playbook that it's going to take somebody an hour to get through, but, how do we summarize this information for, namely provider administrative staff, the office staff, kind of the frontline staff, to be able to understand the interoperability regulations, as well as, what can we do to really maximize the use of the interoperability regulations. So there's a number of use cases that we've highlighted where we collectively, as a provider payer, we want to work together with our provider systems, to drive to improve the care of our collective member or our patient. The other thing we are doing with the provider playbook, we really want to highlight and promote the popular free apps. So you heard JP talk about CommonHealth, you heard Apple earlier present, but we want to promote these apps and really educate our provider staff so that they can get out there and talk about this with our patients and really share what is possible, what is capable with the interoperability regulations. So the way we've developed the provider playbook, we've developed it from a template perspective. It is something that we're looking to share out with other health systems, other payers. Really our goal on this, the way I like to think about it is really a grassroots effort around how do we promote interoperability? How do we get it out to our providers, our health systems, get it out to that frontline staff and talk about not only what is required, but what is possible through interoperability and really promote it. And looking to share it across the nation with a number of different health systems to really get the word out around interoperability. Thank you, Steve.
All right, thanks everybody for your remarks on the panel. Appreciate the updates and keep it up. So we're gonna transition now quickly to the next section, which as we know, there's different areas of friction that happen when it comes to data access, deploying new apps. You heard some of the updates just before as part of the prior panel. And we're gonna move into a section as part of the agenda that we called More Data, Less Friction. We have two industry stakeholders that are going to give some updates on what their organizations are up to from a broad-based industry collaboration perspective. And the first person I'm going to turn to is Ryan Howells from the Kare Alliance. Go for it, Ryan. You're double muted.
Steve, can you hear me now?
Yeah, you're good to go.
Awesome, thank you. At the Kare Alliance, we are focused on getting consumers digital access to their healthcare information. So as we go to the next slide, we are a group of multi-sector stakeholders that are focused on the ability for individual consumers to access their data with less friction. This is an opportunity that we have as an industry to, as we mentioned at the outset, for opportunities where APIs exist now in the healthcare industry at scale. And we have the ability for these individuals to actually get incredibly empowered with access to their health information. We have 4 announcements we wanted to make tonight on how the Kare Alliance and our community is advancing the ability for consumers to get access to their health information. Next slide. The first is we launched earlier this year what we call myhealthapplication.com, which is a series of apps that have attested to the Kare Code of Conduct, which is an industry set of best practices for how apps should handle data in the FTC regulated space. We are very proud of the list of those apps that are on there, that they have attested to that. And we have heard feedback from the industry, especially the payer community, that one of the things that is needed more than anything is for these apps to physically attest, meaning sign the Kare Code of Conduct so that they can have that information on file as they prepare to be compliant with the CMS rule in July 1st of next year. So we've done that. We've reached out to our app partners. They have physically docu-signed the individual code of conduct and specifically the version that they've attested to. And as a result of that, we have those listed on the My Health application website. We also have a number of payers that have actually gone through the process of taking the Karen Code of Conduct and either use or plan to use in production the version of the Karen Code of Conduct so that we can have some consistency in how apps that are currently not covered by HIPAA should handle this data outside of HIPAA. We also have a certification program that we work with ENAC on, where ENAC has the ability now and is acting as a third-party certifier of these apps, both in terms of a basic self-attestation process and option, and then also more of a comprehensive third-party accreditation process as well. And so we'd encourage you to reach out to ENAC to gain some more information on that. Next slide. We also wanted to announce the tremendous progress that we've made for the Karen IG for Blue Button. That's the ability for individuals to access all of their claims and information, almost explanation of benefit information from a payer of their choice. We had a Connect-a-thon November 18th and 19th. We had over 95 people participate in that, more than 40 different organizations. We had more than 10 servers, 10 different apps participating, many of the large payers. And they made tremendous progress in being able to connect to that information, that data. We also were pleased to see that CMS posted on their blog post that Fire Release 4 is coming to Blue Button 2.0 API by July of 2021, and that they will be following the Karen IG for Blue Button standard, the HL7 standard that's been in place for us, for the entire industry to be able to be on the same version of Fire and the same implementation guide after July of 2021. Both the private sector and the public sector will be on the same version of Fire in providing that claims data to individuals. Next slide. We're also happy to report about the progress of what we call Notes on Fire. We had an opportunity just over the last few weeks, actually. We recognized the deadline for being compliant with US CDI and specifically Release 4, Fire Release 4 isn't until December of 2022, but we did notice that some health systems wanted to go early. And for those that went early, we had an opportunity, one of our partners, BeWell, had an opportunity to actually connect to that third party, to that health system's Fire endpoint, and as a result was able to pull down clinical notes. So you see here the screenshots. This is just a part of what's actually going to come in the future as we see many different apps be able to access this notes in production as they come online. Our partners at Open Notes have 2 new survey questions where they're going to start to track that for the industry at scale. And so you'll be able to see that on their map, which of those systems, health systems, have actually gone live early in advance of the compliance date of December of 2022. Next slide. We're also happy to announce today a landmark paper that we have spent much of the last year writing and developing with a number of different partners on what we're calling digital identity and federation in healthcare. You can access it right now on our website on karealliance.com on the homepage, or on our digital identity section of the Karen Alliance page. The reason that this is so absolutely transformative is for a few different reasons. Number one, when we talk about identity in healthcare, the first thing most people talk about is a universal patient identifier. And while that would be valuable in many different ways, there is an opportunity for us to make progress even without that patient identifier. And we have put together a process with our industry stakeholders on the process that could be followed by the industry to actually solve digital identity and allow patients the ability to develop their own digital identity credential. We are also announcing today a special partnership with the OpenID Foundation, where the OpenID Foundation and Kare Alliance are going to partner to develop a technology approach for how to federate digital identities in healthcare using OpenID Connect in 2021. So more details about how you can get involved in this effort will be available early next year. Our call to action is very simple. Implement the Smart App Launch Framework as the ONC and CMS rules have determined. Step 2 is really engage an identity provider that can create or receive a NIST 863-3 Identity Assurance Level 2 digital credential. and an authenticator assurance level 2 credential of AL2 or higher, and then engage with an appropriate conformance requirements of a trust framework organization that's listed in our white paper. And step 3 is start to engage with us in 2021 around the work that we're doing with the OpenID Connect Foundation and how we're going to participate in identity federation pilots with multiple relying parties, so we can develop an approach as an industry and as individuals about how identity federation could work in healthcare to really allow an individual to be in control over their own personal identity credentials across system. We want to make this happen in 2021, and we're excited for all of the work that has gone into this approach and excited to start to pilot it in next year. And with Steve, I'll turn it back to you.
All right, thanks very much, Ryan. I'm glad you had that timer going. So I'm going to turn it over to Reese Robinson, who is going to talk about Graphite Health. Take it away, Reese.
Okay. Says that another participant is still sharing.
Hey, Reese, I got your slides pulled up. You can go ahead and just roll with it.
Okay, well, I'll just give you the notes then. Well, Graphite, thank you. Graphite is a group of like-minded but different-sized healthcare systems and philanthropic organizations coming together to address a common problem. The problem we're seeking to solve at Graphite is the inability to effectively use digital technology in the delivery of care. This lack of digital integration increases cost and causes variability in care delivery. But core to this issue is our inability to transform is the lack of data standardization. Every system operates with their own data structures. There's no plug-and-play compatibility, and healthcare lacks a lingua franca, a common language for communication. Next slide. So what you see here is a good representation, really, which is of healthcare as it exists today on the right side. Non-nimble block-headed fish, too small to be relevant in digital transformation, but too big to be nimble. And we're vulnerable. We're vulnerable to bigger systems, big retail, and big tech. However, this digital inefficiency that we have can be addressed by aggregating resources around this common problem. We can take a playbook from my partner, Dan Lillenquist at Intermountain on Civica. If you hit the next slide, we can create like-minded healthcare systems, aggregate them against a common problem via an organizational construct that creates a public utility, owned and operated for the benefit of all stakeholders. So in this framework, Graphite is an independent digital development company. We're addressing the problem by creating alignment around a common problem and purpose before profits. Specifically, Graphite is a not-for-profit organization owned, financed, and governed by leading healthcare systems and philanthropies. Graphite is a trusted entity governed by the Digital Hippocratic Oath, and a key output of Graphite is data democratization via a public utility platform. Next slide. So the three things that we're doing here are, one, we're creating a collective, and it's modeled after Civica, and it's the mechanism by which we fund and govern Graphite. We anticipate at least 30 million patient lives involved in the collective. The next slide, is a common data model upon which each system can access, manage, and aggregate their information. This is a trusted data layer, and it's made possible by many of the efforts from people that are on this call, CMS and ONC rulings and API standards. The next slide, please. The key thing here is it is coupled with a marketplace, and the marketplace is the locus of value creation, as it's the repository of tools that lead to inefficiencies, actionable insights, and better care. And this marketplace is very unique. It's an open and innovative ecosystem with no barriers to free market activity. Yet it's a secure marketplace governed by the Digital Hippocratic Oath. So it represents a trusted location for patients, providers, and systems to discover and download software tools. The last slide part here. All of this activity is governed by the digital Hippocratic Oath. It is our North Star. The digital Hippocratic Oath serves as our ethical foundation for how we approach everything: data sharing, integration, security, technical processes. It's this ethical compass that allows us to create this trusted and certified repository of tools. And the concept of trust is center to Graphite, because we feel as though trust is both aggregating and differentiating. So if you're interested in learning more about Graphite, we've got our website up. You can contact us, and we're actively involved in the process of moving forward and getting this really as an operational system that will alter the trajectory of healthcare. So thanks, Steve.
All right, thanks, Reese. So we had Reese and Ryan. Thanks very much. We're going to transition over to our next cluster of folks. That is going to focus on provider directory collaboration. And so I know this is a topic that was brought up earlier by Administrator Verma. It's an effort that many of us have been involved in across a bunch of different use cases and initiatives. First, we're going to hear from Nate Mudd, who is the Director of Product Development at CMS, April Todd from CAQH, and Kathy Hempstead from RWJF. So turn it over to Nate first. Please jump on in.
Hey everyone, like was already mentioned, I lead product development over here at CMS for the consumer-facing parts of both Medicare and healthcare.gov. I'm really thankful to be here and have the opportunity to talk to you about one of the products that we have, the Marketplace API, which we launched about 5 years ago. In that time, we've learned a lot about what has worked and hasn't worked with delivering provider directories. Just a quick overview, the Marketplace API powers the current window shopping and plan enrollment experience on healthcare.gov, which helps millions of people each year enroll in health coverage. In 2015, we had a couple of decisions. We launched a couple of decision support features that allowed consumers to see if their provider and/or drugs were covered by plans in the marketplace. And in conjunction with launching these features, we made the data and logic available to third parties via an API. To be successful, we needed to work closely with health insurance companies so that they could deliver us their provider directories and drug formularies in an easy and reliable way. Right now, we have about 141 health insurance companies providing us their provider directories and drug formularies. We crawl, validate, import, and expose their data daily and make it available to healthcare.gov consumers and folks using this API. While healthcare.gov is our primary consumer, about 15% of all of our marketplace traffic is from third parties. Of those third parties, the majority happen to be web brokers and also tax preparation companies like Intuit. So we've learned a lot of lessons the hard way, and hopefully I can run through some of them with my remaining time. The first lesson we learned was the data we got from health insurance companies wasn't great. It was stale, it was incomplete, inconsistent, and many of their files were not well-formed JSON, which was one of the requirements. So we did a few things to handle this. While we had to rely on issuers' data for crosswalking plans to providers, we found it was better to use one source for all demographic data rather than relying on inconsistent data from individual issuers. In our case, we used NPES for provider data and NIH's RxNorm API for drug data. Second, where many processes at CMS have a very, very long feedback loop, our philosophy was if we could crawl data and get it up as quickly as possible, or tell issuers their data was bad, it could be corrected just as quick. Next, we enforced strict compliance measures that offered a number of carrots and sticks to ensure they delivered quality data and kept it fresh. And lastly, some of the data we know to be valuable to our customers was really hard to keep accurate. For instance, whether a doctor was accepting patients was very difficult to keep fresh. And so we often end up having to encourage customers to call their provider. This might sound a bit obvious, but the most important thing we did was set up biweekly touch bases with issuers to understand their pain points about submitting their data. And on the API side, we set up similar meetings with folks who are heavy API users. Second, we weren't overly prescriptive on how they accomplished their delivery. Essentially, you just had to drop a few JSON files in a publicly accessible place and match our schema, and we could take care of the rest. Next, we realized if we could give folks self-service tools, it improved the feedback loop and didn't require our resources to spend as much time hand-holding and being in meetings. We also made sure that the schema was very simple to understand. I will admit there was no Fire spec at this time, but we spent a lot of time trying to get our homegrown schema as simple to understand as possible. And finally, we didn't try to recreate the wheel. So where we could adopt standards and processes that had already been established, we leveraged them. And lastly, we automated as much of the process as possible and encouraged issuers to do the same. So today there's very little human involvement with our data collection, the reporting and compliance efforts, and the delivery of what goes up on healthcare.gov and what comes out of the API. Thank you so much. It was a pleasure talking with you, and feel free to reach out if you want to continue this conversation.
All right, thanks, Nate. Appreciate the update. And we're going to turn it over to April from CAQH. Thanks, April.
It says that someone else is sharing, or if you guys could put up my slide. Okay, great. Well, thank you, and good afternoon, everyone. As it mentioned, I'm April Todd from CAQH, and just a little bit of background on CAQH before I get started. CAQH is a nonprofit convener of healthcare industry stakeholders that for over the past 20 years has created consensus-based solutions for administrative business challenges. Over the past few months, we have engaged with the industry to develop a national fire endpoint directory for health plans, Medicaid agencies, and third-party apps. This directory will simplify how payers and app developers find and establish the more than 300,000 trusted organizational connections that will be needed to help consumers access their healthcare information via Fire APIs.
Hey, April, do you mind hitting full screen? I think you clicked it, but it didn't kick in.
Is that better?
Thanks so much. Yeah.
So the work that we've been doing really has built on the work of the ONC Fire at Scale Task Force, CMS, the Da Vinci Project, some of the work you've heard from Ryan earlier today on the Kare Alliance, and a variety of other industry efforts. The directory itself is intended to provide a single source of truth that will allow payers to share information about their endpoints and for third-party apps to consistently share information about themselves with payers in one place. It will also allow payers and third-party apps to query payer endpoints and make connection requests for multiple use cases, including patient access APIs, the provider directory APIs that we were just talking about, the payer-to-payer data exchange, and many more. It will also facilitate trusted connections among these organizations by validating the identity of payer and third-party app participants, collecting information on privacy, security, and data use provisions, and also performing conformance testing and validation of endpoints and the ability to connect to those endpoints. So what we wanted to announce in our time today is that later this month, we will be launching a beta of the National Endpoint Directory to test with early adopters. And we are planning a full production solution to support the industry in the March to April timeframe of next year. So to learn more about what we're doing, please visit our website listed on the bottom of the slide at caqh.org/forum/keepmeintheloop to learn more about what we're doing and to receive up-to-date information on how to engage with us. So thank you.
All right, thanks for the update, April. and we're going to keep on rolling. So I'm going to turn it over to Kathy from the Robert Wood Johnson Foundation. All right,
Hello.
you're good to go, Kathy.
Yep. Let me just want to share my screen. Okay, is good?
Yep, just full screen and we'll be all set.
Yeah. Okay. Hi, everybody. I'm Kathy Hempstead from the Robert Wood Johnson Foundation. Great to be here today. And at the foundation, we're really interested in trying to support open data efforts, both for research and also to just improve interoperability in the healthcare system. And we have a number of projects that you may be familiar with, like Health Data for Action, and we have a public use file, HICS Compare, that has data on plans in the individual and small group market. And we're also really interested in coverage and expanding access to affordable healthcare, which is why we've been interested in improving consumer decision support in the individual market, and have gotten, along the way, very interested in provider directories, which have been a real pain point for all healthcare system participants, but especially consumers who really struggle to find accurate information about providers that might be in their networks. So that's why today I'm really happy to announce a new collaborative, which is a project that we're funding Care Journey to lead, which is an open data collaborative to use the schema.org standards to help improve the quality of provider directories. And this is just a little bit of an example on this slide of how schema.org has been useful in some other contexts, particularly around COVID-19 in terms of standardizing information on the web. So this is just a little sort of illustration of how we might use schema.org in the provider directory context. And so, you know, we believe that adding structured data from provider websites in a format that schema can help standardize will reduce the administrative burden required to really produce more accurate provider directories. So we wanted to announce the official launch of this collaborative effort today. And there already is a pretty robust multi-stakeholder group that's been participating in this effort, but part of the purpose of announcing today is to try to make other people aware, because I think this effort will benefit from more participation from public and private stakeholders to help provide feedback on the portfolio of tools that we're going to be developing to standardize provider information using schema. So it's very fortuitous that today Anish Chopra, who is the CEO of Care Journey, of course, and really the leader of this effort, has just published a very nice blog on the schema.org website that will importantly provide some more information about this project, but also will give others an opportunity to join us, because I think this will be disseminated and adopted more quickly and be much more successful if we can get lots of participation from stakeholders in the healthcare system. And then when the tools are complete, to really assist with dissemination. So that's really my message today. And I'm really excited that this project is finally kicking off and looking forward to working with everybody on it. So thank you.
All right, thanks, Kathy. Don't want to make any, next year predictions, but it seems like 2021 is shaping up to have some interesting work going on in the provider directory space. So everybody stay tuned. With that, we're going to keep on rolling. We have an update for those of you that have previously attended the Blue Button Developer Conferences in the past. We've had the benefit of having a number of the tech companies that also have a cloud presence. So we call them the cloud-related commitments that they've made at past BBDC, to use the acronym, events, and we called them all back to continue to give us an update. First, we're going to hear from Jason Oxman, the president and CEO of the Information Technology Industry Council, and then we're going to dive into each of the particular companies that have updates to make. So take it away, Jason.
Thanks so much, Steve, and thank you for your service to our country and making this initiative a high priority for the administration, for the government agencies that are involved, and for partnering with the private sector. It's been an incredibly important effort since launch in 2018 that we've been involved in, and we appreciate the initiative. Technology, of course, continues to revolutionize the healthcare industry. Sadly, we've seen during the course of the terrible pandemic that's gripping our nation and indeed the world, the importance of technology to healthcare in the midst of the current COVID-19 crisis. For example, technology companies, including the technology companies that you'll hear from today, are helping communities and citizens and governments track the virus, helping with the computing power necessary to research and deploy vaccines, and accelerating the use of healthcare so all Americans can access their doctors without leaving home. In 2018, as I mentioned, ITI and several of our member companies committed to working together with our partners in government to remove barriers for the adoption of technology for healthcare interoperability, particularly for those healthcare technology needs that are powered by the cloud and AI. The goal of the commitment was and continues to be the use of technology and data to deliver better health outcomes for individuals at lower cost, all while protecting privacy and promoting transparency. So over the last 2 years, we've shown, and look forward to setting out for you today, that such an effort is indeed possible with partnerships with global stakeholders, including patients, healthcare providers, as well as developers, device manufacturers, employers, and researchers that embrace important open standards and interoperability. I'm thrilled that members of ITI, the trade association of the technology industry, including Amazon, Google, IBM, Microsoft, and Salesforce, are here today to share their progress to advance this important effort. As this pandemic has demonstrated, healthcare innovation is an ongoing and an evolving process, and it's critical that the robust public-private dialogue about healthcare interoperability continue to further advance this important cause. And with that, and with our thanks for all the participants in this important effort, I'd like to turn it over to our partners from Microsoft to update on progress on this initiative.
All right, thanks, Jason. I understand that Microsoft's AI bot won the most rock, paper, scissors round. So Peter Lee is gonna go first, and I will turn it over to him.
Thank you, Steve and Jason, and great work. And we're very proud to be here. And I'm joined here by our Corporate Vice President for Microsoft Health, Greg Moore, our Chief Architect for Healthcare, Josh Mandel, and our General Manager for Health Data Platform in the Cloud, Heather Cartwright. Just to recap, we did make a commitment to remove barriers for data interoperability. And when we talk about data interoperability in health, we think about the entire health ecosystem. And so working both with our partners, for example, like Walgreens Boots Alliance on pharmacy data, or with Walmart and Kroger on consumer data, or partners like Humana, Providence, and others on electronic health records and hospital visits. We've been doing what we can to remove barriers to advancing health data interoperability. Next slide, please. To get a little bit more specific, we've had a very busy year working to deploy a large number of enterprise grade and enterprise scale products and services, mostly in the form of APIs, both as managed services across our cloud, as well as open source in every case. Some of these are foundational for a health data platform. Some enable the application of AI and data science to extract health insights. And in order to make it easier for companies to adopt all of these tools and services and APIs, we've packaged them together into a single product SKU called the Microsoft Cloud for Healthcare. And that went generally available just last month. And so we're very proud of that progress. Next. You should look forward to more. First off, we are still absolutely committed to working with Amazon, working with Google, IBM, and Salesforce to jointly do what we can to make sure that the cloud ecosystem is a great place for advancing health data interoperability. But we also want to do what we can to accelerate standards and community engagement. So for example, we're very proud of our leading support for all three of the Argonaut 2020 projects, and we intend to continue and even expand as opportunity allows. Next. We're also finding great alignment between our business interests and the acceleration of production deployments. And just to make one call out, we're just thrilled at the great work that Humana has been doing, having just now made a production deployment of the Andor Smart on Fire application within their Conviva physician group. And the next stages of that to provide Blue Button and additional Fire APIs, including support for things like connected medical devices in the home to improve virtual care experiences, we think are very exciting. It's just one example of many that are now possible that we have actually deployed products and services. Next. On transparency, fairness, accountability, and ethics, Microsoft has a governance process and a review process called Ether. And we've just recently expanded the Ether process now to cover applications of AI and data science technologies specifically to health data and specifically to health data in FHIR format. And so that expansion of our governance process, I think, bodes well. We think that this has been a very good thing for the world. And then finally, we can't reveal too much now, but we are hard at work on a couple of things. One is, as was called out earlier, we are very interested in the next stage of data interoperability based around digital identity management and doing that in a way that protects privacy, puts consumers in control. And so we'll be doing much more in that space, but we also see a great need to connect real world evidence and medical research to these platform foundations. And so stay tuned. Thank you.
All right, thank you, Team Microsoft. So I'm going to turn it over to Ashima Gupta from Google Cloud.
Hi, truly honored to be here today. I would like to begin by thanking ONC, CMS, Office of Science and Innovation at the White House, and several of my industry colleagues for the passion and purpose you all have around advancing interoperability for our country. Google joined the cloud commitment because we want to lower barriers for standard-based data exchange and to unlock a marketplace of trusted health applications that compete on helping doctors, patients, and care teams and help them make better decisions. Since we last spoke, we have furthered our commitment in 3 important ways. First is the launch of the Interoperability Readiness Program. Working alongside our customers for past several months, the conversations have changed from why interoperability to how interoperability. This program aims to assist providers and payers manage this transition. Achieving interoperability is not just about technology. It is about building an ecosystem, and we are proud to play our part in making it a reality. This program, with the support of our incredible partners, Deloitte, Bain, SADA, Maven Wave, KPMG, and several others that are listed on the slide, will assist both payers, providers, and guide stakeholders along their interoperability journey and set the foundation for long-term innovation and success. In our work with many clients from many different industries, we have synthesized learnings on how to build and deliver modern connected experiences at scale, including not just what technology is available to them, but what KPIs, metrics to track for a secure and privacy-preserving API program. What internal competencies need to be developed, what kind of developers need to be hired, and how to build a multi-year API-first strategy. So we are very proud of launching that. It was launched yesterday. Second, we have continued our work in supporting standards natively in Google Cloud Product Stack. The Cloud Healthcare API went GA back in April. It has a native support for a FHIR R4 and also native support for the bulk data processing. We are continuing to support the community with a solution architecture blueprint and have launched Health API X. Think of that as a test bed and a reference implementation. It has a pre-built developer portal to test FHIR standards, and we are also working with organizations like Kare Alliance to further this work. Our hope is that it will nurture a robust and thriving developer ecosystem. So as we reflect the lessons of COVID-19, I believe building resilient, interoperable health infrastructure at scale will not only be catalyst, but table stakes for delivering better care. Thank you for having me here, Stephen, and proud to be part of this journey with all of you.
All right, thank you, Ashima. So we'll turn it over to Sean from Salesforce. Take it away, Sean.
Great, thanks a lot, Steve, and thank you for that nice introduction. I'm joined today by Ashwini Zanuz, our CMO and Senior Vice President for Healthcare and Life Sciences. Next slide. So Salesforce is proud to continue to support our healthcare system's path toward interoperability. We have continued our investments in API development, integration orchestration, and standards adoption. We're also pleased to see their expanding applicability and utility in light of the ONC CMS interoperability rules, as well as the COVID-19 pandemic, a time when data accessibility has proven more critical than ever. Salesforce continues to advocate for APIs and patient experience as each become more prominent across healthcare. Central to a great patient experience are APIs, because ultimately a CRM is much more valuable when extending a source system, and patient access is only useful if you share needed data in a consumable format. Next slide. We will continue to meet our customers where they are, which means continued support for HL7 V2 type electronic data exchanges. We will, however, continue to modernize and scale interoperability through the more widespread use of APIs. We commit to API-based interoperability and have adopted Fire R4 and US CDI as part of our API and data models within MuleSoft and Health Cloud, respectively. In support of the rules, we have built the provider directory, formulary, and patient access APIs. And plans are using these APIs as a means to help them meet the rules. Then by leveraging Health Cloud, they're going beyond the rules by using those APIs to help deliver more value-added services to the patient and member and provider. Additionally, providers are using our APIs to help them secure and scale their integrations, thereby helping them extend the value of their EHRs, as an example. Further, we've developed a few notable demonstrations, Smart on Fire app in connection to fire.epic.com. Smart on Fire app works in conjunction with EHRs, enabling clinicians to add patients to relevant campaigns and studies. The fire.epic.com work demonstrates how quickly we can connect to an EHR, Epic in this case, pull data into Salesforce, and enable providers with a 360 view of patients in support of access center and care management use cases. Finally, as a founding member of the cloud information model, we continue to deepen our ability to interoperate with other cloud providers in order to ease connectivity, irrespective of industry. So thank you, ONC CMS, for your leadership, event organizers, Matt Lira for driving our collaboration, and Anish, as always, for working your convening magic. And thank you to other cloud colleagues for your collaboration. We're thrilled and honored to commit to interoperability for a third year in a row.
All right, thank you, Sean. I'm going to turn it over to Shay Partovi from Amazon.
All right.
There you are.
Fantastic. I don't have any slides, so we'll just go as is. My name is Shay Partovi. I head up healthcare, life science, and genomics at AWS, a physician by training. Practices in healthcare, life science has been around for about 7 years. And what maybe I want to share with you today is to reiterate that to us, data liquidity is absolutely paramount in getting the right information from across the continuum of care to the point of care so positive action can be taken. As a physician myself, recognize the importance of data liquidity and interoperability, and standards is one of the ways in which, key way in which data liquidity can be achieved. And in that regard, AWS has released an open source toolkit, because our role, actually, just to back up for a second, our role really isn't to build apps that might be used by a patient at AWS. We empower our customers to build tool sets that then would allow information to be brought to the point of service. And so we see ourselves doing the undifferentiated heavy lifting to make it easy to adopt these standards and to do the work. And so in that regard, we released an open source toolkit called Fireworks on AWS, which really allows the undifferentiated heavy lifting to be done for our customers, our partners, healthcare systems that want to build Fire-based tools. And that tool set allows two things fundamentally. You either embed it in your application and it brings that Fire API standard to your application, or sometimes many systems and many customers have legacy data, and it allows that to be unlocked. And so one specific example I want to give you is the work that's being done at Rush University Medical Center. They're led by Dr. Balahota. You probably are aware, it was in public domain, that Rush University Medical Center is working with the Chicago Department of Health in order to collect data, create a public health hub around COVID results, sort of the electronic lab result reporting. And what is an example, a terrific example of us providing the tool sets and our customers and partners using those, is that Rush University, working with AWS, will then take that electronic lab result that's been sort of resulted and use the FHIR standard to go out and get additional enrichment data for that particular individual. And so this is really the heart of what standards, of course, it helps achieve, is the idea that you can go out and not just be a catcher's mitt, but actually go and get data. So using these tools I just shared with you as an example, working with Rush University Medical Center and taking an electronic result, in this case, a positive lab result for COVID, to go out and then use a FHIR API to actually, without integration work, to get all that data. This is the heart of population health. This is the heart of registry formation and following populations. And this is the heart of consumer empowerment, because a single atomic piece of information can then cascade, getting enrichment data to derive deeper meaning from that one result, because it's not by itself sufficient. So we have leaned in, we will continue to lean in, like our colleagues that have been on the call today. This is an area of utmost importance, and data liquidity will stay front and center for us as we empower our customers and our organizations to bring the right information so positive action can be taken for patients and individuals everywhere. Thanks so much, Steve, for the time. I hope I got you back on track.
That's helpful. That's helpful. Thanks very much. And I want to introduce Michael Kare from IBM Watson Health, who's been patiently waiting as the cleanup hitter for the cloud group. So Team Cloud. So take it away, Michael.
Thank you. Yes, I like that cleanup hitter. So I lead products for Watson Health within IBM, and I'm excited to be here as well. Thank you to HHS and ONC for your leadership. IBM remains committed to the same things everybody else has been talking about, so I won't spend too much time on that. But I think this idea of evidence-based decision-making is critical across all aspects of healthcare. And so we work with our clients to help produce those better health outcomes using evidence-based decision-making. We ultimately believe that our clients and their patients should be able to work across different products and services from across different healthcare systems with the confidence that those systems are going to work together seamlessly, right? And that they're going to have the best care possible looking across that landscape. So that sort of idea of a longitudinal record that spans across no matter where you're getting your care, no matter what kind of care that is, and no matter what part of the care cycle you're in, that's critical to us. And all of this is really grounded in a belief around our century-long commitment to responsible stewardship of data and responsible stewardship of advanced technologies, including things like AI and blockchain and the cloud. And of course, IBM embraces openness. It's core to our existence. We've always been a very open architecture, open standard-based company, and we're continuing that with the adoption of standards like FHIR and Smart on FHIR, and ultimately, helping our clients to adopt interoperability. So if you look at what we're really doing here and how we're approaching interoperability, we have three core things. One is we're providing an open platform with out-of-the-box Smart on FHIR support. The second is we're delivering Watson Health clinical portfolio, our entire clinical portfolio, as Smart on FHIR applications. And third, we are fostering an ecosystem of partner applications on our platform. So the first one of those, the platform that I was talking about, is really IBM's Touchstone certified open source R401 FHIR server, along with IBM's Consent Manager, which is a unique open blockchain-based consent management technology that allows the patients to have complete self-sovereign ability to provide access to whoever they want to provide access to portions of their health records. In addition to that, we leverage our core technologies around IBM API Connect and App Connect, allowing us to provide the highest level of security around APIs and then ultimately integration of those APIs into backend systems. If you think about the clinical portfolio within Watson Health, we're starting to transform that and move that over to Smart on FHIR as well, so that it becomes accessible within those EMRs. So I'll give you 3 examples. The first one is Micromedics. Micromedics is our online drug information reference. It's used by about 4,500 hospitals and health systems worldwide. It provides evidence-based insights for clinical decision-making, and that can be delivered at the point of care within an EMR leveraging Smart on Fire. Second example is iConnect Access, which is our leading zero footprint imaging viewer that comes out of our imaging technology base. And this can provide imaging report retrieval, direct retrieval of data through Smart on Fire APIs from the EMR, and then ultimately push results back into the EMR leveraging Smart on Fire. And then lastly, our annotator for clinical data, which is our core clinical natural language understanding technology. This can be embedded directly, again, into the EMR to enable the ability to process unstructured data like clinical notes as a part of the natural processing. So as a clinician is entering notes, you might want to, for example, check to make sure that there's nothing in the clinical notes that might have been missed in the orders and therefore might represent an error in the orders. So that kind of processing can be happening naturally behind the scenes using our annotator for clinical data. So these are the types of innovations that we're making. We continue to move forward on both the back-end Fire server technologies and the front end of these different applications that we're delivering in the clinical level. We're continuing to work with a number of customers and partners. We're always open to working with more. And if you're interested in working with us, please feel free to reach out to me directly at currymi@us.ibm.com. Thank you.
All right, thank you, Michael, and thank you for wrapping this up. Now that we've heard about all the heads in the clouds, we're going to go right down to what's happening on the ground and move into our next segment, which is going to be focusing on provider apps and the ways in which our colleagues in the field have been addressing API usage and how they're changing the ways in which providers usability, access to data, in-context workflow, and changes in that area of work. So first, we're going to have our colleague from MedStar Health, Kristen Miller, do a brief intro of their work, and then we're going to turn it over to Dr. Ken Mandel from Boston Children's, and then wrap it up with Ryan Bramble from the HIE in the Maryland area, CRISP. So take it away, Kristen.
All right, thank you. Good afternoon. I'm Kristen Miller. I'm the Scientific Director of the National Center for Human Factors in Healthcare at MedStar Health, and the PI of a 2018 ONC LEAP Area 2 Award, Advancing Knowledge at the Point of Care. And I'm representing a much larger team today that includes MedStar Health, Care Journey, Asymmetric, and Centra Health. The ONC was really interested in well-documented and fast emerging challenges in health IT. So we had 3 main goals of our project. First, from a human factors engineering perspective, to support evidence-based clinical cognitive support, really thinking about clinician workflow. Second, to think about how to transform standalone risk calculators into the EHR and really embed them into the main EHR using Smart on Fire technology. And then third, thinking about communication between providers, but also between the patient and the provider to help them understand their own risk and modifiable risk behaviors they can do to improve their health. So with permission from Cerner in this demo, you'll see that the tool is embedded in the main landing screen of the EHR. And we used different Fire resources to be able to do this. So anytime a provider opens a patient chart, then when Fire resources are available, then information will be populated. You'll see hover over functionality that tells you how recent the information is. The providers are able to copy and paste information into any place that they want to document. And this was a request specifically from providers that there may be different notes where they may want to enter this information. Clinicians can also link out to different guidelines. So you see here a provider that's linking out to the ACC AHA guidelines, but they're also able to link out to internal MedStar guidelines, which was a specific request from our clinical councils. Perhaps the most exciting part of this is that the clinician is then able to navigate to the patient-facing Smart on Fire application, which we call the Risk Educator. And without writing into the record, clinicians can make changes to patient data to be able to show them how different risk factors can change their overall risk. So in this example, showing someone if you lower your cholesterol, how the actual risk differs from the estimated risk. And what we've seen here is really providers inviting patients to be a part of the EHR to really see how their own data becomes this risk calculation. And then again, this idea of modifiable risk behaviors, so really understanding what they can do to change their behavior to make improvements to their health. So our tool launched in February of 2020. So I'm showing you 7 months of data here. In that time, nearly 400,000 events logged and almost 200,000 successful ASCVD risk score calculations. This includes over 1,500 educator manipulations. So that's the patient-facing tool, and almost 300 instances of a user reviewing guidelines. So you can find more information. The tool is publicly listed on the GitHub page and also in an ONC blog that was posted today. And we look forward to working with other healthcare systems looking to deploy the tool. Thanks.
All right, thanks, Kristen. And amazing work from the MedStar team as part of our LEAP Awards and the GitHub information we wanted to make sure that people were aware of as well. So sharing the wealth. I'm going to turn it over to Ken to talk about what's up at Boston Children's. Go, Ken. You're in the double mute purgatory that I was in earlier. So both in the app and on your phone.
There we go. How's now?
You're good.
Okay, fantastic. So thank you, everyone. And thank you, Don Rucker and Steve Posnack, especially for putting this event together. I'm going to talk about how Cures sparks the health apps economy for patients, providers, and populations. I want to look back historically so that we can understand where we're going. In 2009, I wrote a piece with my colleague, Zach Kohane, about how EHRs could be reimagined as smartphone-like platforms that run apps. The goal here would be that an app written once should run anywhere in the healthcare system. This provides a market where apps are substitutable, easily added, or deleted as on a smartphone. What we needed was an API. And this vision, and it's unbelievably exciting to see an entire afternoon spent just on APIs now, is very analogous. And I want us to reach very high. And so I want this analogy to be clear. The World Wide Web instantiated just a few standards early on. Tim Berners-Lee said the dream behind the web is of a common information space in which we communicate by sharing information. Its universality is essential. We could then use computers to help us analyze it, make sense of what we are doing, where we individually fit in, and how we can better work together. He did this with HTML, HTTP, a web browser, and a web server. In Cures, the API is similarly instantiated as a specific tool of interoperability. And the 1,000+ page rule tells us very specifically how that's going to happen. It creates an apps economy for patients, providers, and populations. I want to look at what ONC has invested and how we can use what ONC has done as building blocks into the future. So their initial support of our work on Smart on Fire in 2010 led to the Smart on Fire API. Tremendously gratifying to see this used in so many of the presentations and projects today. Substitutable apps. As Ricky Bloomfield showed us, and as CommonHealth is now doing with Android, that allowed this at-scale interoperability so that the Apple Health app could connect to 600 health systems. That tells us that this model is working. ONC funded us to create an app store for health, a live app directory so that apps can be discovered and tested against a sandbox. ONC in 2018 asked us to create an analogy to the Smart on Fire API for populations. we now have the bulk fire API. Thanks to incredible skill at getting these APIs regulated, both Smart on Fire and bulk fire access, as we've seen today, are regulated in the Cures rule under ONC. In 2018, ONC funded us to actually think about an apps economy around bulk fire. It was terrific seeing Kristen's presentation about a widely used within MedStar and deeply integrated risk calculator, cardiac risk calculator. It was actually our first smart app, was a cardiac risk calculator inspired by Wired magazine. And under LEAP, we actually created population apps using bulk fire. Here's the population analog of the first Smart on Fire app, a panel management cardiac risk score app. We were asked also to add the patient voice. What we heard in bulk fire is, well, we're trying to create metrics for payment and for value. We've got data coming from the electronic health record. What about data coming from the patient? So we're working on the Smart Markers project. The code is available on GitHub, and it's a framework for creating patient-generated data apps. And most recently, ONC has funded us to think about going from data, bulk fire specifically, into knowledge, data to information to knowledge at scale. How do we do interoperable, scalable, universal knowledge generation, getting information out of electronic health records, recognizing a critical interface between the cloud and the electronic health record? So we've got the building blocks. We see them today in this incredible array of projects and initiatives. Remember, the goal is that an app should run anywhere and analytics should run anywhere. With Fire as a lingua franca and with universal apps launch, we have the capacity to truly be interoperable and to focus on the things that matter. So if we adhere to functional definitions of interoperability so that an app written once runs everywhere, and we all strive to keep things interoperable, not just to the letter of the law, but also beyond, not just to the regulated implementation guides, but to the latest implementation guides, we will get value-based care, real-world evidence for drug development, payments and prior auths, research, biosurveillance, AI and ML to the point of care, genomic medicine, COVID contact tracing. We created this graphic in homage to the 10 years of work that this whole community is doing. There's a lot more that we should squeeze into here, including things we've heard today, and we will. But it's a journey, it takes a village, and everyone is now driving towards the same goal. I just want to reiterate that the interoperability functionally, so that things work everywhere, is truly the goal. I'll put in a fast plug for our faculty search, and I will turn it back over.
All right, thanks, Ken. And I will flip it over to Ryan from CRISP, who's going to talk to us about what's going on in the HIE space and how HIEs are also playing a role in the in-context experience for healthcare providers. Go ahead, Ryan.
Great. Thank you. So for those of you who don't know, CRISP is a health information exchange that serves Maryland and whose infrastructure is shared amongst 4 different states: DC, Connecticut, West Virginia, and Maryland. We're a nonprofit HIE that's been around for about 10 years and have been recently developing a lot of our own software applications. What I'm going to demo today is our Smart on Fire app, which has been running for a couple of years now. It's live in Epic and Cerner. We're very close with ECW and Point-Click Care. It does what you'd expect an HIE app to do, displays clinical information inside the app, inside workflows. It also does a good job with public health data. It's connected to PDMPs in a couple of states. It's connected to RxCheck, which is the national PDMP API that's coming out of the federal government. We've been working with APHL AIMS to have it work in some e-case reporting functions. And then we also were just awarded a ONC LEAP grant, which will help in partnership with the American College of Cardiology work on clinical registry submission and data display as well. This is something we've built with federal money, so it's open for folks to use. We're working with other states outside of those 4 who are using the app for different reasons. So I've got it set up this way on purpose to show you that the app basically lives in the side of an EHR. I don't have an EHR to show it in, but this is basically what it looks like. What I'm on here is the PDMP advisories page. You can click over to see the PDMP itself, PDMP data itself. This is the connectivity out to RX check. So if I hit Nebraska and then, sorry, didn't check it there. If I check Nebraska and then query that state, it'll go out, it'll check for the PDMP data and then refresh. And then I can sort this to show both Maryland and Nebraska. It also will show clinical data, as I said, so I just click the clinical data tab here. This is the lab reports you'd expect the HIE to have, radiology reports, clinical notes, encounters. It's also showing some infection control alerts. This is where the COVID positive and negative results will display. This is where some other important information a person might need to know about other potential infectious diseases would display here as an alarm. We've also done a lot of work integrating with care coordination systems to provide the names of the care team. So this patient goes to Kaiser. If they were in a food insecurity program and some of our social determinants of work, that would display here. We've done some work with advanced directives, especially in West Virginia, to show end-of-life documents. And then we've done a lot of good work with all of our states on claims data. I don't have any sample claims data to show you, but we pull in claims data on a pretty regular basis. In DC, it's every 2 weeks to show meds list, diagnosis, procedures, and encounters from claims, which Medicaid claims, which really gives you a good comprehensive view of a patient if you're a Medicaid patient. This also expands out the full screen, so you don't have to necessarily run it in the side of your EHR. You can run it as a full screen app. And we continue to iterate on this. We have a team of devs that are working essentially on this app every 2 weeks, deploying new features. And it's something that we hope to see more widespread in the future. Thanks.
All right, thanks, Ryan. Cool work. Appreciate the updates from your side. And we have reached the point where we are scheduled to take a break, everyone. So we are running a few minutes behind as best efforts go. I'm going to propose we do a 3-minute jumping jacks break. We're going to get our panel assembled, and we will try to assemble pretty close to 10 after the hour. So be back real soon.
Hi, Grace.
Love your background there, Ashima.
Thank you. Rasu, how are you?
Doing all right, thanks. Hanging in there.
I've been following your tweets. Awesome.
Gosh, thanks. Yep.
All right, I think we've got just about everybody. Lucia, you out there? All right, there you are.
I'm here.
Cool.
Sorry, I'm trying to manage my
Great.
calendar because you guys are running late.
Yeah, sorry. Appreciate everybody's time. So we are at the final home stretch here, and I'm going to just turn it right over to Grace Cordovano to take it away as the moderator for our panel. We're going to just reflections on today, optimism for the future, other types of things that everybody's looking forward to for 2021. So take it away, Grace.
Wonderful. Thank you all so much. What an afternoon. So I'm the patient advocate that Steve alluded to earlier. My name is Grace Cordovano, and I'm a board certified patient advocate specializing in the oncology space. Just a little bit about me. My day-to-day is working with patients and their loved ones from point of diagnosis through survivorship or end-of-life care planning. And after being in this advocacy space personally and professionally for over 20 years, one of the common denominators that impacts all people with a diagnosis is how difficult it is to get access to the information you need when you need to make an informed, educated decision about your care. And that's why I'm so passionate about this space. I am completely wowed by this afternoon. So as Dr. Don Rucker was saying, there's much to celebrate here. From the point of organizing such a powerful event that was so succinctly delivered over the course of a single afternoon. I'm absolutely amazed by the level of collaboration across all stakeholders. If COVID-19 has taught us anything, is that working strategically together makes us stronger, and that's crystal clear from just this afternoon with all of the updates that everyone has shared. I wanted to share too that it's important to celebrate progress, and there's literally probably blood, sweat, and tears from both this administration and key entities and stakeholders and individuals who have worked tirelessly, both past and present. So that's to be celebrated. I wanted to share that a colleague earlier this week and good friend shared a tweet with me that really resonated. And it was a tweet from a parent that said that their 8-year-old son carried emergency confetti in their pocket and was waiting to use it for good news or in the event of a celebration. So after listening today, I'm going to use my confetti in my pocket and celebrate what we did today, because I think if anyone needs celebration, everyone here should get a round of applause. And on that note, I want to introduce this amazing panel who needs no introduction, but I'm going to turn over to you all. Give me a quick 60-second overview, and I'm looking at you, Ashma, to get us started, please.
Thank you, Grace. And it's truly special that a patient advocate is moderating this panel. This is Ashma Gupta. I'm the global director. I lead the industry strategy, including product and solution roadmap for healthcare and life sciences at Google Cloud, ex Kaiser Permanente. So I come from the rich industry background. And in my role, we are looking into building forward-thinking solutions, and interoperability through my work at Apogee is near and dear to my heart. So thank you for having me here, Grace.
Rasu.
Thanks. Just really excited to be here. Rasu Shrestha, I'm a radiologist by background. I am the Chief Strategy and Transformation Officer here at Atrium Health, and really excited about the conversations that have been had this afternoon, and even more excited about how that then can be a platform for amazing, even more amazing work that can happen in the years ahead. So looking forward to the conversation today.
Lisa.
Great. Lisa Berry. I'm the CEO of the Strategic Health Information Exchange Collaborative, and also run a consulting firm called Emphasis Health. And previously, I was in charge of health IT and interoperability policy at the CMS Innovation Center, and I've worked with many of you in various other forums before, and super happy to be part of this conversation today.
Lucia.
Hi, everybody. I'm Lucia Savage. Right now, I'm Chief of Privacy and Regulatory at Omada Health, which is an 11-year-old digital health and digital care company. But I wanted to tell Ashma a fun story. I remember before Apogee became a member of the Google family, and we had some Apogee people come to help us do our API task force. Steve is thinking, oh yeah, there's that. And it's really great. That was a late summer of 2016, and it's really great to see all of this work we did with so many collaborators so many years ago start to bear fruit.
Hi, everyone. I'm Firdaus Pathena. It's a privilege to be part of this august group. I feel highly underqualified to be on this panel. We are, of course, users of Apogee, and as one of the largest health companies in the world, we are, very interested in how we can make use of all the wonderful things that we're talking about here to make a difference in our members and our consumers' lives. So thrilled to be here. Looking forward to the discussion.
Wonderful. Thank you all for making the time to be here. And I want to dive right in. So I want to start with really talking about what excited you from this day's events and announcements. And I'll start from the patient and care partner perspective. I have to say that this is one of the first events that I've been to that over and over. Actually, I'm kicking myself for not taking a tally of how often patient access, the need for the patient to have the information. The patient has been emphasized from start to finish, and that's something that is powerful and important and is really refreshing to me, because I think that there is a different level of seriousness here, and I'm excited at the prospect of what the future really holds with APIs in healthcare. I have to say I'm absolutely in love with the Simple Report project. And on the same side of the coin, I'm concerned because how are we actually functioning in a pandemic when we see photos of stacks of papers and we're using fax machines? All of those workflows and manual processes are second nature to anyone who is a patient or the primary care partner to a patient. So I'm thrilled to see something like Simple Report. I loved seeing the Girls Computing League clinical trial selector for patients at the VA to look for clinical trials. If you have looked at clinicaltrials.gov, it is not the most user-friendly site, and we know that enrolling in clinical trials is so difficult. So it's a breath of fresh air to see a newer way to do it and developed by a school team. I'm also loving the standardizing info on the web that schema.org presented. So if you all would want to jump in on any of the things that excited you from today or from the industry in general.
I would say great. I think it was very heartening to see how the smart IT community is a small one. It is a special community. The progress that we have seen, some from providers, VA, NIH, some of from our competitors, everywhere, I think there is that collective feeling that the rising tide lifts all boats and how we are all in it together. To me, it's pretty inspiring to see the collective action and the progress that we have made and the realization that the APIification, or it's a journey, there's a realization, even though like we are all starting, we are here in for the long run.
This is Lucia. I'll take a stab at it. I think the thing that was so exciting to me is kind of the number of disciples. To really pull this across the line, we need stories of success that that ripple out into the ordinary world. And I just had a tweet exchange today with, somebody had written an article about we have to teach patients about APIs. I'm like, I don't need to know how the API works to use my online banking tool. I trust my bank. It seems to work. The money looks right. I haven't been to a bank since February. When was the last time you went to a bank? And so I think that the storytellers, to take everyone, there's 473 people on this webinar today. If you all tell 10 stories, that's 40,000 stories, and each one of those stories turns into another story. Pretty soon, we have stories that build confidence in what we're trying to do.
I love that. And if you know me, you know I'm a huge fan of stories and storytelling, and that's the way to get messages across. And I think that that's definitely an opportunity for us as an industry and in this ecosystem to really bring humanity and empathy to it and tell stories. And I love your point. I don't need to know exactly the technicalities of the API, but it works and I trust it. And we'll get onto the topic of trust a little bit later in the discussion. Does anyone else want to share something that excites you either from today or APIs in healthcare in general?
Sure, I'll go if you can hear me. Just really quickly, you know, I think I was actually really heartened to see that there's definitely progress since last year, a lot of progress, which is wonderful and a little bit surprising, but also, you know, the pressure and the necessity and the urgency of this moment certainly is moving some of this work forward and hopefully starting to push down some of the barriers that, you know, were there before, artificial barriers, obviously, but still there were barriers there before. You know, looking at it from a perspective of the HIE community, and not just for HIEs, but in general, are we making sure we're using what we already have in place, right? Are we making sure that we're not leaving something behind that's already been built? I think that's one thing that's obviously an HIE related perspective. You have these connections, you have these things already built, connections already made. How can you connect those things to the broader infrastructure? That would be one thing I would look at. And also looking at all the work happening across all of the different agencies. You know, I was part of this in the recent past. We need leadership. We need leadership that connects all of this amazing work that's happening. If you're watching this and you're not sort of familiar with how life works in the agencies, you know, how this work actually happens, these people have been working on these projects for years. The idea that, you know, only industry or only outside folks or an administration leadership can do this, that's not true. This work happens because people have been carrying that water for years and years and years and years, as many of us can attest. And so we need leaders who will push up the work that's happening in the agencies, in private industry as well, in all of these groups and collaboratives and nonprofits, pull it up, bring it together, provide the resources, make it happen. The raw materials are definitely there, as you can see. So I hope that if there are folks watching this who are taking new leadership roles, they say, oh my gosh, this work is happening. How do we keep it going? How do we connect it? How do we push it up? That's what I'm really hopeful for after seeing this, that people will see this and realize it's happening already.
If I can chime in, you know, we talk about surge in a very negative sense. You know, this has been 2020 after all. But what I sensed this afternoon was a tremendous surge in the way that we've actually embraced APIs across the industry. It's now not an exception, it is now the norm. And if you're not doing it, then you're definitely missing out. I saw three specific things I was really excited about hearing about the work that Graphite was doing. And how, you know, there's an independent digital development company that puts purpose before profits, and how health systems actually coming together for the greater good, for public utility. And I think that's exactly what we need in the post-COVID era. I was really excited also about the provider directory collaborative APIs and the schema.org discussion that was there, and Anish Chopra's blog that is now live on that website. So really excited about that and what that will do for patients overall. And then thirdly, very excited also to hear about open notes and notes on fire. I think, you know, building off of the success of open notes is really, really important. At Atrium Health, as a large provider organization here across the Southeast, we've been early adopters of open notes and really pushing the envelope forward to make sure that, you know, the notes are readily accessible to patients and their families. And there was a paper that we published recently where we said, hey, look, here's what we did. And this is a study that we'd done with Boston Children's and Beth Israel. And when we found that, you know, that the findings show that patients, when they have access to their reports, they're able to really call out potential errors in their notes, and it vastly improves the accuracy as well as the patient safety element. So there's real lives behind these APIs, behind the FHIR work that we're doing. So this surge that we're seeing is tremendous, and it's actually positive for once.
I love that. I think if we can put a positive spin on anything, and surge is such a great word to capture it all. Firdaus, what excites you about APIs in healthcare?
So I'm a techie at heart. So APIs and technology in general is certainly interesting and exciting. And we work with Google, we work with other, big tech partners in the space, and have talked to Rasu and Ashima and others in the past. But that's not really the most exciting part, is it? Right? What's really exciting is, we as part of CVS now, we come in touch with, close to 100 million health consumers over the course of, every year. Look, today we're testing over 100,000 people a day for COVID. We're getting ready to vaccinate tens of millions of people, right? I mean, this is the kind of stuff that moves the needle in the healthcare space. And what I'm most excited about is that we're all starting to look at this not as a set of technology solutions, but more as a more from the outside in, which is something we talk a lot about at CVS Health, which is how do we translate all this technology into meaningful and impactful health experiences that make a difference in the lives of people. I agree totally with what Lisa said earlier, right? We are not today, as an industry, making enough use of what's already available. We just aren't. We tend to, and this is because it's in our nature as technologists, I think, to keep pushing the envelope on a lot of different fronts. And certainly that's really important. But sometimes I think it would help to take a step back and say, are we really building that end-to-end experience that's going to make a real difference in somebody's life? Or are we making just incremental progress in 12 or 15 or 30 different areas that doesn't move the needle enough for anybody? That's something I'm very curious about. I'd love to hear other people's thoughts on that. But at the end of the day, you're right, Grace. Nobody cares about how the API works, right? I've been married to a pediatrician for 27 years almost, and never once heard her say the word API, but always heard her get frustrated about the lack of access to the information that she needs to do her job better for the patients she cares so much about. So I think that's the perspective I'd like to add to the discussion.
Well, this is a great perspective, and think one caution also, right? The regulations are strict, but that's API-based interoperability is more than the regulation, and doing it for the right reason. It can be truly transformative in building the learning health system and creating those digital experiences that are powered by APIs, but they're means to an end. At the end is not to meet a timeline alone. It's how do you build a robust ecosystem and build a meaningful experiences for both physicians, patients, care teams, and so on and so forth.
I love that. And I want to focus in on the word lives. When we talk about transforming lives, a lot of this is an emphasis on patients, but I want to point out not to forget about the primary care partners. Those are the people who are there caring for the person who's chronically ill, who has a cancer diagnosis, who's experiencing severe side effects, who may be dealing with a life-altering, life-limiting diagnosis, a disability, a rare disease. These people are healthy but need access to information, or they're also trying to juggle all of this while they're managing their own health condition. It can't be this complicated. So on the concept of transforming lives, we also can transform providers and our doctors, nurses, care teams' lives. Other professionals, even though they don't touch the patient, could actually now play a profound role in transforming people's lives when they live with their diagnosis because of the digital app economy and these new regulations and policies and technologies. I want to shift a little bit because the conversation has been said that while we have the technology, we now have the policies, we have the regulations, but I want to hone in on the role, or if there is a role, for trust. Specifically, what role will trust play in the success of accelerating APIs in healthcare? And I want to look at it through the lens of between stakeholders, providers, payers, the public, private sector, and then also between stakeholders and then patients and consumers. Rasu, I'm going to look to you first. Talk to me about the implications of trust between stakeholders.
Well, thank you. It's a really important topic. Trust has been one currency that's been put to the toughest test in 2020, if you think about it, right? Whether it's in terms of the trust around the data that we consume online and elsewhere, or specifically in terms of the relationships, right? We've been through a trifecta of challenges as a society overall. The disease burden with COVID and all the other diseases that just haven't simply disappeared, the financial hit and the economic impact, and then lastly, the societal impact, the racial inequities and disparities that the pandemic really shone a light across. And so when you think about trust in the context of all of that, we as a health provider system have really been going all out and saying, all right, we have to embrace the social impact elements of what it means to live through a pandemic and what it means to really come out on the other side. We're widening the aperture and really recommitting to the elements of the disparities that exist in care venues out there, making sure that we're able to connect more tightly to not just the patient, but really the persons, the communities that are out there that are consuming health services and the information that exists or doesn't exist out there. The education element of this is really important as well. So there's so many elements to this where, API, Fire, all of the technological advancements that we're talking about just becomes more invisible as we're talking about, but really feeds into strengthening the elements of trust, which is really important. At Atrium Health, we believe that we're on the cutting edge of medicine and science, and I think that's really important. A lot of health systems aspire to go down that path as well, but I think it's also important for us to be on the cutting edge of inclusion. Yeah, because everyone deserves the best care possible, and trust becomes such an important element to that. So let's make sure that all of the technological advancements, the surge that we're seeing here around the embrace of APIs, et cetera, really then feed into building and growing and nurturing that trust.
I love that. Firdaus, I want to ask you from your expertise in your corner of the world, what role does trust play here in the success of APIs?
So first of all, I think we all recognize that, trust is very hard to build over a long period of time and very easy to lose, right? When I first became part of CVS Health, we discovered that, or we were told that, there is a tremendous amount of trust between, for example, pharmacists and the patients who come in to speak with them. We looked into that with our research team, and we tried to figure out what is it that actually helps people build trust. And a lot of it had to do with real, true interpersonal relationships that haven't gone anywhere, in spite of all the virtual activity happening right now. But I think it's very much based on transparency, openness, and a willingness to let people in and see what you're doing with the information that they're trusting you with. Typically, when some kind of a scandal happens out there, it's not usually because somebody's doing something malicious or nefarious. It's because they didn't approach it with the transparency. It's usually more of a PR snafu than anything else. Some of the people on this call know some of the examples I might be referring to, but it's a PR snafu. It's a matter of not being open about communicating transparently about what you are intending to achieve with the information you are going to use. And I think that will go a long way towards helping us build that trust that's going to be essential to transforming health with digital tools in the future.
Thank you. I couldn't agree more that trust and transparency definitely go hand in hand. Lisa, I wanted to ask you if you could comment on the role of trust between stakeholders and patients and consumers.
Yeah, absolutely. I mean, I think if you look at the Cures Act final rule and the CMS interoperability and patient access final rule, and you look at kind of the mechanism by which they and of course the law, the 21st Century Cures Act, were sort of the framework there, it really goes down to patients having an obvious right to their data and information, and sort of building out from there and carrying that over to other settings. At this point, stakeholders in healthcare, whether they are providers of various types, health IT vendors, health information exchanges or networks. In some cases, they're waiting for more guidance. They're waiting for an additional rulemaking. They're waiting for the specifications to start sort of sharing information in the way that's specified in those rules or guidance or regulations or laws. But you know, it really comes down to, at the end of the day, we know what people expect here. If we sort of look inside of our hearts, not to get too touchy-feely here, if we look inside of our hearts, we know what feels right to us about trust and patient health information and patients accessing data. You want to know who's going to access your data. You want to know what they're going to use it for. You want to be able to direct it and opt in or opt out at a fairly granular level. You want to, you know, probably make sure that nobody's profiting off of your data. Those are things that are really usually important to people. So I think that, you know, what we need to say here is, as healthcare entities, as these non-patient stakeholders, we don't need to wait to start implementing some of these frameworks that are coming out. The Kare Alliance obviously had a great presentation right before this and talked about frameworks that they're advancing and finalizing. You don't have to wait for regulation to do the right thing, because regulation will come and laws will be passed. We can probably say, we can anticipate that happening in the future. But I think starting to do the right thing right now is really important, especially as we're looking at more and more data being shared. When we look forward to the hopefully coming this month COVID vaccine and all the work that has to happen there and all the patient information that has to be shared, it's really critical that we get this right. And honestly, you know, nobody at this point has the excuse of, we need to wait for the regulation of the specific guidance from a government entity. We know what to do. Enough frameworks that are draft or almost finalized exist to start doing the right thing there. But trust is going to be absolutely critical to moving into this next phase of information sharing. And every entity, everyone on this panel and everyone listening and anyone who's working in the space probably can affect this themselves. The other thing I wanted to say is, all these things we're talking about, like you said, the technology is there, the standards are there, the APIs are there. What has to happen on the ground, and that's why I loved the Simple Report example, is workflows and culture change. That's a much bigger piece of all of this. Like, again, we have the technology, we have the APIs, we have the standards. What we don't have is everyday work to create new workflows and adapt and change the cultures on the ground. Again, I don't blame those people for building piles of paper. They had nothing else to work with and an absolute critical emergency. But that's what happens if we don't work to shape the workflows and move fully into digital when we allow these silos and these paper bridges to continue to exist. So above anything else, you know, you have the sort of the trust level and us knowing what we have to do now. We also have this really foundational work of workflow and culture change right in front of us. So
agreed. Thank you. And you know, I'm going to throw this out there as an advocate. Every single person wants to live their best life where they are. They want to live their life with dignity. They want to leave this life with dignity. And when we look at digital health, digital transformation, I encourage everyone to think of the concept of preserving digital dignity. What does your digital dignity look like? All of this information, whether they're assets, whether they're health information, whatever they're considered in your corner of the world, that concept of do no harm and really elevating the apex of ethics here, transparency and trust, I think is important. I wanted to ask Lucia, could you share any examples from your respective arena of how trust is really a catalyst that's needed
Sure.
for acceleration?
Sure, and while we're talking about it, and it's December now, I can point out that in fact, the patient right to get a copy of their own data will be 20 years old on December 28th. So in 2016, somebody asked me, you know, where did this new law come from? And I'm like, well, the law is like 16 years old. So for all the lawyers and policy wonks, it's an old law, and it's really a fundamental part of the right, the healthcare transaction. And to Grace's point, I think another component of building trust is not making life harder for your people when you're in the professional capacity. We don't want to, if I were a physician, and I'm not, I just play one on webinars, I don't want to increase my patient's anxiety and stress by making their path to whatever they think they need more difficult. And being where I sit in a company that delivers all their care with humans in an asynchronous digital environment, if we make it hard, we lose our people. When was the last time you kept using an app that was hard for you to use? Let's be clear about that. And so we've actually been on a very specific path of using the trust that our patients have with our coaches and our platform as we build out our business relationships with key clinical partners that our patient needs us to communicate with in order to deliver the care. So it could be a CGM manufacturer, it could be a pharmacy to know if that CGM has been mailed, all of that kind of stuff. So we've actually been using and are working on the process to launch in the spring, right in the app, a patient can say, oh, I get it. You need for me to let you give this information to a pharmacy partner so that you can get the fulfillment I'm expecting you to deliver without me having to get a piece of paper and sign a piece of paper and mail a piece of paper. And God forbid you should have to find a fax somewhere. So great dialogues with our business partners about what the rules say. And this is not literally under the ONC rule. This is high tech and the normal provisions of HIPAA. Really looking at what the laws, to Lisa's point, what we already know the laws say, and how can we collectively, for our collective responsibilities for these patients, make their lives easier, make it easier for them to get the care they need so that they're not spending their lives worrying about their care, they're spending their lives.
I love that. So thank you for reminding us that it is December. So with December now start the predictions for the coming year. Russell, I'm putting you back in the hot seat. What are your expectations, knowing what we know now with all of the updates that we got today for 2021 and beyond? And I'm going to put my expectation is that we're going to be able to put fax machines back in a museum where they belong.
Well, I certainly hope so as well. When I think about, all of the advancements that we're hearing this afternoon and everything that we've done, even in the last couple of decades, interoperability and this transformation in terms of liberating data has truly been a tumultuous march forward, right? It's been a true crawl, walk, run. We were crawling in the first decade with interoperability, with competing agendas and conflicting vendor standards. We were then walking in the next, where industry started to learn to put one foot in front of the other and actually walk and have some level of coordination. And I think in the next decade forward, we could truly have an opportunity to run. We're more aligned around the patient, with more open standards and APIs becoming the norm. So will the fax machines be relegated to the museum? I certainly hope so. But I think it's more than just that. It's about making sure that we don't make the mistakes that we did in the prior decades with EMRs not being interoperable. When we think about the app ecosystem, when we think about the connected ecosystem of not just apps but also devices, it's really important to make sure that we don't make the mistakes of the past, that as we run forward, we're able to truly make this more patient-centered, and we're not focused on competing standards that don't essentially talk to each other.
Yes, please, let's not run in silos. We need to run forward and get to some type of a finish line that we can all be proud of. Lisa, I'm going to ask you for the same expectations for 2021 and beyond.
Yeah, I mean, I think as I mentioned before, sort of as I intimated, I think that we're in a moment in time where it's obvious that everyone is trying to work towards a very similar goal. I think that a lot of work has gone, up to this point in building the sort of the building blocks, the fundamental platform, the technology, the standards, building on laws that already exist, new laws, new regulations. We have these sort of fundamental building blocks now. And now is really the question, I think really broadly for all of us, both as we look forward, in terms of development and distribution of vaccines, and also whether we take all the work that's happened thus far and really build and really, build on the system that we have today and really build out a public health data infrastructure and broadly a data infrastructure that supports patients sharing and receiving and accessing their information. I feel like sometimes I feel like I'm sort of being a little bit too dramatic about it, but it really feels like so much is on the line for us right now. You know, and I think it is, right? I think that we are, we have a tremendous amount of opportunity, but the stakes are so high. And that goes for us getting through this pandemic, getting out of this pandemic, and also us taking all of these siloed pieces and bits of information and putting it together in a way that, you know, patients and their caregivers can access and use to really deliver on that promise of both, you know, people receiving the care that they deserve, value-based care broadly, cutting the waste out of the system, improving healthcare for all Americans. Again, how many times can we say we have, you know, the most expensive and the poorest performing health system in the world? How many times, how many years will we top that list until we say it's enough? And so I do feel like the stakes are quite high in many areas, and this in particular. So I'm looking forward, you know, with a bit of trepidation, obviously a lot of emotion after having worked in this space for as long as I have, and you all as well in your lives and your work, and saying, can we make this happen? Do we have the right you know, combination of timing and opportunity and passion? And are we going to actually deliver on that promise? So that's what I'm looking forward to. I'd love to see what the new administration brings to the table, whether they're really able to connect the dots and build on the work that happened over the last 4 years. A lot of work has happened over the past 4 years. And then so I'm hopeful. As I think I mentioned before as well, I want to see us use and build on work that's already happened, infrastructure that's already there. I think obviously HIEs are a big part of that. You know, not every community has an HIE, but many or most do. What can we do to strengthen those, expand those, bring patients into the fold? HIEs, as an example, haven't really been patient and consumer facing in the recent past. And so what does that mean? What are their obligations, just like any health IT vendor or provider? You know, how do we bring those pieces together? So that's what I'm looking forward to, and that's what I'm hoping to contribute to and work on, probably with many of you.
Wonderful. So stakes are high. We all know that. But there's a lot of hope, and I feel a lot of positive energy. So we all know a very wise person that has repeatedly emphasized compete on services, not on data. What will APIs in healthcare really mean for patients, guys? Talk to me about choice and transparency. Can you give me examples? I'm going to look to Lucia first.
Sure. Well, I was just taking notes. What I really want to have happen, particularly in that regard, Grace, is because we've opened up the data, we've made some really amazing new possibilities for innovation. And one of those is innovation that addresses health disparities. For example, I'd like to see a whole universe of apps that collect a patient's data and analyze it in a way that meets their cultural needs. There's some great innovators working on that space relative to, like, you know, culturally appropriate providers. And I just think there's a lot to be done in that space, whether it's religious preferences, your cultural background, your language, your level of English facility, all of that. So I think that could really be an amazing outcome over probably 3 to 5 years of this channel. The second thing is, I think the physical footprint of buildings is going to change. The care is going to come to the patient instead of the patient is going to come to the care. The $28 parking fee to get your immunization shot might be a thing of the past. At least I'm hoping it will be, because I don't like paying all that parking either. And then lastly, you know, this comes at a time when the silver tsunami is really about to crest. So if you haven't heard that term, it means it's the digitally savvy baby boomers. I will count myself in that category. You know, we know how to use a smartphone. We like the convenience of it, but pretty soon we're going to be in Medicare. And so the silver tsunami is coming right at the same time that we're opening this up. And so I think that there's going to be some great opportunities for people who need caregivers, the family members of these aging baby boomers, to really create the virtual teams and the virtual communications tools that suit their family's lifestyle, whether that's everyone connecting through Alexa, and if we want to have a conversation about Alexa and HIPAA, we can, or an app with multiple users that are sharing the same information. But there's some really great opportunities for empowering our aging population to live independently as much as possible, while still being, you know, somebody's looking out for them.
We're only scratching the surface here, and I'm sitting on the edge of my seat. Ashma, can you tell me what your thoughts are on choice and transparency?
I would say, Grace, I think my esteemed panelists have covered that topic. Trust and transparency go hand in hand. And just like APIs and the policies that we have and who has access to the data, the same thing is about transparency. How, if I wear my patient or a consumer hat, I would love to know how my data is being used and for what purpose. And that's where the transparency lies. And I have a strong belief that we have the technology today, and especially that's what APIs provide. When you're sending faxes or CDs versus when you have a digital mechanism to exchange this data, you have much better handle on those logs, auditability, how the data is like the provenance, the path the data has taken is much more, we call it access transparency. It's much advanced now. Now, we also talked about data and APIs are at the end means to an end, like how's that data being ultimately used? So both trust, transparency, and I think one important topic here is patient consent. Let patient make their choice, and that's where I will have full agency on my data and who I want to share it with and for what reason. And that framework around consent APIs and getting that API level granularity, policy enforcement, and who has the access, having a robust analytics. That's the beauty of the API management. That has been done in the other industries, and that same discipline and same technology infrastructure needs to come in, because as the industry is embracing the API first programs or API first strategies. I also want to mention, as we're looking into the recovery, right, where you talked about what is exciting, there's a collective realization that future will not look like the past. And while the recovery is gradual, we are seeing many of the healthcare organizations reimagining that future today. And that's the exciting part, that what we will build now is how the healthcare will look 2 to 5 years from now and maybe longer. In sitting where I sit, I see 4 areas. We talked about digital care delivery. This is robust digital applications, which could be clinician facing, patient facing, built with the security and privacy preserving ways. The second is around the operational effectiveness and the efficiency and automation. So when we talk about claims processing, revenue cycle, there are many, many applications for AI machine learning into that back end that also needs to be looked at from the lens of automation. Can we help better that from the operation efficiency and automation perspective? The third area that we see are like forward-leaning innovations, things like digital pathology, the work we're doing in radiology, all that requires multimodal analytics, connecting your imaging to your EHR record, to your financial records, and that's where the patient access APIs, it gives the transparency on the financial side. Your EHR has your visit data, and your radiology or the images data sits in the PACS. Can we do the multimodal analytics and build new models of care? We will see brand new business models in digital pathology, radiology, and in the, as I mentioned, the back-end automation as well, by applying healthcare NLP, speech to text. This tremendous opportunity as we look into the future in how we co-create this together, and at the end, keeping patient at the center.
Wonderful. Firdaus, I want to turn to you and talk about what this is all going to mean regarding quality and outcomes. Would you share from your perspective, please?
So, when it comes to quality and outcomes, I think what I think, we'll be most focused on, and this is going to be enabled by a lot of the technologies we talked about today, throughout the afternoon, is going to be putting the patient in charge of guiding their health journey. And I think that's to me a big improvement in the not too distant future. Hopefully starting next year, going through the next 3 to 5 years, there's going to be a sea change in the way, health is not kind of something that's done to me, but health is something that I do for myself. given tools that I have at hand. Look, I came from the world of tech into digital health a little over 4 years ago. And, you know, we were just talking about choice and transparency. And when I first heard about this whole cost transparency thing, I thought, well, how can this be so hard? Like, isn't there a price list somewhere? Just put it online and let people see what things are going to cost. Boy, was I wrong, right? And I think we're finally coming to a place where by putting the right information in front of the health consumer at their fingertips at the right time, we give them the power to control the quality of care they get and to have a greater influence on the outcome. And by giving them that responsibility, along with the capability to manage that responsibility, I think we have a chance to really transform how this industry works. I think I see this too often, both in my personal life and in sort of our professional, careers, where it so much feels outside of your own control. And so much of it feels like it's just being done to you without, really any say in the matter. And I got to say, doesn't it tell you something about where we're coming from? And this is taking a leaf out of Lisa's book to say, do we really need to have all these regulations to make us do the right thing? We really need to look in the mirror, right? As practitioners of the art, all through, provider systems, Rasu and Lucia and us as, large, entities that touch so many people in the value chain of health. We shouldn't need regulation, right? We shouldn't need all that unnecessary overhead to do the right thing for the health consumer. And I think the quality and outcomes that we all aspire to achieve will come naturally if we make sure that we keep that consumer at the center of everything we do and do what's right for them.
I don't think we could have wrapped in a better way, unfortunately. I do think that we could have sat and chatted at least until next Tuesday about all the things we're excited about. But I'm going to leave on this note. A lot of times that there's a pushback that patients can't handle the information, that it's going to cause anxiety, that it's going to cause stress. They're not going to know what to do with it. And from my experience in my advocacy world, information quells anxiety. It empowers. And I think we're only scratching the surface of the greatest patient engagement, patient empowerment, person-focused movement we've ever seen by doing the work that we're all doing today. So I just wanted to thank this panel. I wanted to thank everyone at this event for having the event and for having me here. I'm turning it back over to Steve.
All right. So, Stefan and I debated the best way to close the session for today. I advocated for the quick cut to black screen a la Sopranos, but he advised me to do something more sincere, and he's one of my senior advisors, so I'll listen to him this time. Working backwards, I just want to express my thanks to Grace as our moderator, the excellent cast of panelists that we had today. It was great to slow things down, especially for me as the MC. But just to slow things down a bit and just, remarkable discussion that was had all around and the ground that you all covered today as part of the panel discussion. So thank you again to all of our amazing speakers, the presentations. It was rapid fire, fast paced and chock full of content. And amazingly, we stayed pretty close to on track despite some of the technical glitches and things that you would otherwise expect from a half-day virtual event. Thank you to all of our attendees. For those of you that stuck with us the entire afternoon, thank you for setting aside the time in your day. We know that time is important to you, and we appreciate your attendance as well here. If you missed any of today's presentations, please know that we will be posting a recording, and all the sessions will be part of that. They'll be made available on the event's main landing page, and we'll do that as soon as possible for us to process the video files and closed captioning and the like. This is an amazing showcase of what is going on today. Hopefully you learned something. That's always one of our goals when we have a session like this, but also a way to showcase and look into that crystal ball a little bit in terms of what is happening in the API space, what's happening more broadly in the healthcare community, and what is in the queue for 2021 and what you can expect to really take off. So there were many other initiatives that we had that hit the cutting room floor this time around. But I love to have that problem because we love to have these types of events, and we can help share and give a platform to our colleagues, both on the federal side as well as in the private sector, that are doing things that are pushing the industry forward. So we will be back in 2021 with more events like this and more opportunities for us to share what's going on, especially in different spaces, maybe different than API focused, but certainly a lot of content and activity in this area as well. So we'll definitely be looking to continue the conversation. If you haven't already signed up for the newsletter through healthit.gov, my one public service announcement for you at the conclusion here, that happens on a weekly basis most of the time. Also, our ONC Buzz blog that you can access on healthit.gov as well. So if you want to find out about anything ONC related, some of our federal partners that we give cameo appearances in the newsletter as well, you can get all that on a weekly basis from ONC through the listserv. And then with that, I want to wish everyone a happy, healthy new year, continued success, and just keep at it and incrementally chipping away at all the work that we have to do. So again, thank you so much for your time today, and appreciate everybody's attendance and contributions to the event. Take care.